Okay, so good afternoon and welcome to the bill hearings for the House Health and Government Operations Committee. I'm your chairman, Jocelyn Pena-Melnick, and my vice chair is actually our new vice chair, Delegate Collison. And she is a little bit under the weather, but she's watching from home, so let's send her prayers for healing. This is our first session back in person since 2020, so I ask for your patience if we encounter any technical streaming issues. And if we do, just be patient, okay? We'll figure it out. Please set your electronic devices to vibrate and don't hold conversations in the committee room while testimony is happening. We're going to hear from the bill sponsor and the sponsors panel, followed by an all in-person witnesses. Favorable first, favorable with amendment, and unfavorable. That's the way they sign up. Then all virtual witnesses, the same order. The bill sponsor testimony is not limited, but please don't take more than 10 minutes. While all witnesses will have 2 minutes to provide testimony. A timer is displayed right on the left-hand side of me on the screen, and a sound will be played once your time has expired. If it has, I'll give you a few minutes to wrap up your thoughts, but please don't take advantage and go on for another 5 minutes. Please adhere to our usual committee rules of one question. This is for the my wonderful members, and one answer from the panel. Now one question and one answer from each witness. Please keep your questions brief. Members of the public will be able to view the live stream of this hearing on the Maryland General Assembly website and YouTube. And today we have 12 bills. Tomorrow we have 16. So that means that keep your questions brief. Remember that we do, I would say 99% of our work in subcommittee, and you'll get to ask questions. Also, a lot of the questions you can ask the witnesses to send it offline. Today we will have the following bill order, and keep in mind that sometime I may change it if I see that someone's not here or they're across the street. And as we actually encounter crossover the next week, our members, you see that if they're not here, it doesn't mean that they don't care. They do, is that they have hearings in other committees as well. So they'll be back, and we're all paying attention. The first bill is House Bill 504, followed by 657, 354, 606, 726, 703, 716, 333, 482, 596, 1148, and we're gonna end with 626. If you notice, Delegate Collison is not here, but her chief of staff will be presenting House Bill 626. First, we're gonna start with 504, Delegate Kaiser, who is already sitting, and I'm so grateful, with her panel, and is the Maryland the Developmental Disability Council establishment. Good afternoon, Delegate Kaiser.
Good afternoon, Madam Chair. So good to see you. Good to see everyone on the committee today. I'm here on behalf of House Bill 504, the Maryland Developmental Disabilities Council establishment. To my right is Rachel London, the Executive Director of the Maryland Developmental Disabilities Council, and to my left, the Secretary Beatty from the Department of Disabilities. I would like to highlight, I'll say at the beginning and at the end of this, that this bill has passed in the Senate unamended and unanimously. So I'll start with that. And to say, oh my God, everyone says it's an easy bill, but here you go. This bill would codify the existing council as an independent unit of state government, allowing it to be even stronger and more effective policy advocate on behalf of the over 100,000 Marylanders with developmental disabilities and their families. I'm going to give you a little history, so neither of the two women have to take up their 2 minutes with that history, but just to tell you that the Developmental Disabilities Assistance and Bill of Rights, otherwise known as the DD Act, established this council to help the needs of those with developmental disabilities. And pursuant to that federal act in 1971, the governor issued an executive order to make the Maryland State Planning Council on Developmental Disabilities. Fast forward so many years, and we're now the Maryland Developmental Disabilities Council, housed inside the Department of Disabilities, but the executive order has to be updated. So although the Developmental Disabilities Act was last updated in 2000, the executive order hasn't been updated since 1987. And this is a problem because while this council is 100% federally funded, it must comply with the Federal Developmental Disabilities Act. I do think moving the council from under this structure And having the executive director and having the secretary, clearly, they're okay with it too. So it should streamline the work. And while they do have a close and productive working relationship, they both agree that this restructuring is needed. And I think it helps to explain outward facing to the world to let people know that it is a completely independent council. And I think this bill will make that more clear. And of the 56 councils across the states, 33 are formally codified this way. And we're hoping, again, to be the next one. So I thank you, Madam Chair, and I urge a favorable report on House Bill 504, reminding everyone of this very simple bill that was unamended and passed unanimously in the Senate. I'll pass it next to Rachel London.
Thank you, Delegate. Good afternoon, Madam Chair, members of the committee. I'm Rachel London, the Executive Director of the Maryland Developmental Disabilities Council. We are a statewide public policy organization that creates change to make it possible for people with developmental disabilities to live the lives they want with the support they need. We do this in two really big ways, obviously our advocacy and policy work, but we are also a grant funding organization. Our policy and advocacy work and our grant monitoring is done by a very small but very mighty staff. You've heard all the history, so really what this bill, House Bill 504, does is it formally establishes the council as an independent unit of state government instead of a program of the department. This is really critical because the DD Act that Delegate Kaiser spoke about explicitly requires us to be independent. It also updates a very old executive order and codifies our authority that's granted under the DD Act, that federal law, into state law. So moving the council from under the structure better aligns with the spirit and the intent of that federal law. And as you've heard, we obviously work very closely with the Department of Disabilities. We are co-located, but that is it. Being within that formal structure is really unnecessary. It can lead to misunderstandings because the council does not operate under the direction of the department or the governor. The federal law actually requires the council's positions, decisions, and actions be solely that of our own. And just for clarity, the council that I speak about, while we have that small but mighty staff, is actually operates like a board and is led primarily over 65% of our council are people with developmental disabilities and their families. So again, in closing, this really just codifies the existing operations of the DD Council as required and authorized by the federal law and our federal funding. Thank you, Madam Chair.
Thank you. Next, please.
Yeah, thank you, and good afternoon, Madam Chair and members of the committee. For the record, my name is Carol Beatty, and I'm Secretary for the Maryland Department of Disabilities. And I want to thank you for the opportunity to testify today in support of House Bill 504. You should also have in your bill file a letter of support from our department. As has been said, the Developmental Disabilities Council is co-located with the Department of Disabilities, but really operates wholly independently. And that being said, the Department of Disabilities partners with the DD Council on many issues and projects that benefit Marylanders with disabilities. For example, our work with the DD Council during the COVID pandemic response and recovery resulted in Marylanders with intellectual and developmental disabilities and the people who support them being prioritized for both testing and vaccination. And currently, we are working with the DD Council to expand the availability of accessible and inclusive playgrounds throughout the state. Preserving our very effective partnership with the DD Council is very important to the work of the Maryland Department of Disabilities. This bill will not impact any of our current or future work with the Council, so I urge the committee's approval of HB 504.
Thank you for being with us, and thank you for your work. We really appreciate your work. Are there any questions for this panel? Seeing none, you convinced them it was an easy bill.
And thank you again, Madam Chair, and for accommodating the Secretary's schedule today. Thank you so much.
My pleasure. Next, we have Laura Howell. Good afternoon. How are you?
Good, thanks. I almost fell off my chair. I'm so excited to be in front of HGO. Good afternoon, Madam Chair, members of the committee. I'm Laura Howell with the Maryland Association of Community Services here today on behalf of the Developmental Disabilities Coalition, which is 5 statewide organizations. I think most of you know the coalition very well. We are here with a very simple but hearty support for House Bill 504 and the establishment of the DD Council as an independent unit. We work very closely with the council on policy issues to improve the outcomes and quality of life for people with developmental disabilities in Maryland, and we think that this bill is a very straightforward bill that will strengthen the council, and we value their work and we urge a favorable report.
Are there any questions for this witness? Seeing none, thank you so much for everything you do as well, okay?
Thank you.
And this actually for the committee concludes the bill hearing on House Bill 504. Next, we have House Bill 657, Delegate Johnson, Maryland Medical Assistance Program, Employed Individuals with Disabilities. Will you be so kind if you have a panel and bring them up? Thank you so much. You are it. You are enough.
Thank you, Madam Chair. I'm it today. My one panelist, they didn't get signed up in time, so
Okay.
I'll carry the ball today.
You can do it.
Thank you, Madam Chair, committee members. I'm Delegate Steve Johnson. For the record, here to present House Bill 657. Too many bills. House Bill 657, an act concerning Maryland Medical Assistance Program, Employed Individuals with Disabilities, is an important bill impacting Marylanders with disabilities that wish to freely work and pursue marriage without punishment. People with disabilities for too long are statistically recognized as the most underemployed and the most underemployed population throughout the country. Bad policies have held back people with disabilities for far too long. We must do more to support people with disabilities by bringing forward better policies and removing archaic limits. This is happening all over the country, and we should be proactive here in Maryland. The current rules impacting Maryland's employed individuals with disabilities, known as EID program, to many create strict limits on income, assets, and resources pertaining to applicants and spouses. Eligibility limits who are not married to make less than 300% of the federal poverty level and have assets and resources less than $10,000. These limits create major barriers and negatively impact applicants and prospective applicants. Most applicants are forced to get happily divorced before they enroll, or once in the program, marriage then results in losing eligibility altogether. House Bill 657 will change the narrative and will empower workers with disabilities to work without limits and pursue marriage just like everyone else. I would love to talk about a gentleman named Josh Basil, and he's the reason I took this bill this year. This gentleman's 37 years old and lives in Maryland, who became paralyzed as a teenager from the shoulders down. Josh is unfortunately unable to attend today, but plans to testify at SB 572. Josh is a Maryland success story. With Maryland's VR assistance and backing, he graduated from community college, then from the University of Maryland College Park, and then magna cum laude from law school without ever flipping a page with his fingers. Josh enrolled in the Employed Individuals with Disabilities program in 2013, where he became a Maryland barred attorney. Josh has not taken a pay raise at his law firm because if he did, he would be terminated from the EID program and lose all of his caregiving, which he requires to live in the community. Josh has chosen to survive rather than thrive within his career. Josh, on February 23rd, 2022, 1 year ago, became a father to a healthy baby boy. If Josh were married to his fiancée, he would lose all his Medicaid benefits and caregiving. You know, I have often wondered about the way we structure the EIDs for people with disabilities in this state. And to me, it's always been backwards. If a person like Josh, who is handicapped at a young age, but still has the drive to put himself through school, through law school, and become an attorney, have a family, why should we be punishing them? Why aren't we letting them reach their full potential like everybody else in this country? If Josh was able to earn more than $10,000, Josh would be able to put back into the system and help pay for his health care. We know some folks with disabilities absolutely need the care, and I don't think any of us in this committee would deny them that. But to not allow them to be married like everyone else, have a family, pursue a normal life as normal as possible, and contribute back to our system, to me just seems very archaic and very backwards. I'm all for letting anyone that can participate, earn a living, and put back into the system to help pay for their own health care. I'm for that every day, all day. And for that reason, I would ask for a favorable report on House Bill 657.
Thank you for your testimony. I don't see any questions, but I do have a question. The Maryland Department of Health has a letter, and I understand what you're saying, and I agree with it. However, regarding this particular issue, it says the Maryland Department of Health is concerned about the impact of eliminating the acid test for the participant entirely, as required by House Bill 657. MDH has received inquiries about the impact of receiving large monetary gifts, such as $1 million gift, and eligibility for EID. If the provisions with respect to elimination of the acid test in House Bill 657 are enacted, all gifts, including the large monetary gifts of $1 million or more, will be disregarded. So my question to you is, where do you find that balance, right? And I know you can meet with, and you have already with Ms. Roddy, to see if there is a way that you can compromise, because if you are getting $1 million or more, then that's concerning, right?
Madam Chair, as a gift, and I mean, I don't know how many people with disabilities are going to get $1 million gift. I took that letter of concern, and I have some issues with that as well, because our Department of Health no longer shows up to testify very, very few times in our committee. We don't get a letter of support with amendments or oppose. We get letters of information or letters of concern. I took that letter of concern, and most of it says they agree with what we have in this bill. The part about a gift, if they have amendments where they would like to structure to make sure that doesn't happen, I would be happy to work with them on that.
Can I ask you to work on some amendments yourself and present them to Ms. Roddy, and see, before we assign it to subcommittee, and see whether she would agree with it?
Madam Chairman.
Are there any questions for the delegate regarding this bill? Seeing none, thank you so much, delegate. My pleasure. And this actually concludes the bill hearing on House Bill 657. Next, we have House Bill 354. Delegate Chang, is he here? He is not here. So let's go to 606, Delegate Morgan. Public health food products containing insect flour labeling. And if you have a panel, I believe you do, Rachel London. No, that's Delegate Chang. 1 second. That would be interesting, Rachel, for you to be on that bill. I guess it's just you, Delegate. And you're enough. Go ahead.
We'll be very quick. Yeah, sure.
This
Go
is-
ahead. If you'd like one, I have some samples I'm passing around.
Yeah, House Bill 606.
So good to see you, Madam Chair. This is House Bill 606, which deals with cricket flour and the labeling of insects in our food. People are new to the committee. Every so often we have one of these bills that deal with how food should be labeled. The last one I can remember in this committee had to deal with milk, and whether milk is dairy, or was it almond, or goat, or even breast milk. and I think we spent a good amount of time on that. This bill looks at cricket flour. For a long time now, the FDA has regulated it's okay to eat insects. What's changed is it's been a major push by some other countries, namely Canada is probably the largest one. They created new plants to push cricket flour. Now, cricket flour is a product that looks just like ground up flour. I bought a sample of this on eBay. And it's really high in protein, low in fat, and I'm sure it tastes really good. But if it's going to be in our food supply, we should know about it. And this has been a push, I know up in Canada, they are building a plant up in Ontario that is supposed to produce 9,000 metric tons of cricket flour. So it's an initiative that's coming from World Economic Forum to put cricket flour in our food. There's also several health concerns with this. The EU just passed this last month, and it's in the PowerPoint slideshow that I put out there, despite inconclusive data for allergy concerns. It seems that a lot of people that are also that are allergic to shellfish also do have a reaction to cricket flour. This bill, if you read it, it basically treats cricket flour, any products made with insects, as you can see on this little hoppy bar here, the same as imitation crab meat, which we already have on the books in this part of Maryland law. Some of these products couldn't be actually regulated because of interstate commerce, but the problem we're trying to solve is really like this type of powder product, making it into, think like smoothies, maybe restaurants, as high performance meal shakes and products such as that without the consumer knowing. So with that, I'll be happy to answer any questions and ask for a favorable report.
Thank you. Are there any questions for the delegate? We have Delegate Shalega.
Thank you, Madam Chair. So Delegate Gazzoni and I just tried that. Were we eating crickets?
Well, did you just have some?
We tried it.
Well, you're the first people that ate it. So if you are what you eat and you can jump really high, maybe start squeaking, was it good?
I mean, Delegate Chisholm tried it too, but so you didn't answer the question. Did we just eat crickets?
Yeah, you just ate crickets.
Oh,
Yes.
okay, thank you. And the print on it's so tiny, I need a magnifying glass to see if I ate crickets.
Yeah.
So I have another question, Delegate Kaiser.
Madam Chair, I think I'm fine, because I was going to ask Delegate Morgan if it was delicious, but it seems like he was not willing to try it himself, so.
No, I was honestly, I only bought like one pack off of Amazon for the bill hearing, and I was just being gracious. I'll try one after, but I was letting you all have the first dibs at that. And I'm sure we could probably put some in the back room if need be, or make some cookies.
So I don't see any other questions, but I do have one, if I may.
Sure, go ahead.
1 second. If I may, there is an unfavorable from the Maryland Retailers Association. Did you speak with them about their concerns?
I did not speak with them regarding their concerns. They typically testify on bills like this, and maybe they're coming up after me. I don't
They are.
know.
I just wanted to give you an opportunity.
Dealing with labeling, and I understand their concerns about labeling, and there's some stuff because of interstate commerce law that we just can't regulate. But like I said, my biggest concern is products like the powder, making it into like shakes and stuff like that. And I think it just needs to be disclosed to people. This bill doesn't try to take away your ability to eat it. It just discloses what you're eating.
Okay, thank you. I just wanted to give you, oftentimes we testify and we don't get an opportunity to come back. So I wanted to give you an opportunity. I have a question, Delegate. Actually, there's a question from Delegate Woods.
Yes, thank you, Madam Chair. I just want to get some clarity. So, and correct me if I'm wrong, it is my understanding that almost everything we consume has insects or something in it. And I'm thinking particularly of a beverage, when we talked about Coca-Cola, and I don't know if everybody remembers the big thing about Coca-Cola, and they're saying there's so much insects allowed to be in your Coca-Cola before it has to be reported. So it's in all of our beverages, it's in all of our food. What makes this different? Is it the percentage? Because my understanding is that everything that we eat, there is a certain amount of insect or feces or whatever allowed to be in it.
That's my understanding as well, Delegate. There is a certain threshold as far as like cereal or grains that has a certain percentage of insects in it. What this is, it is strictly made from it. So it's like I said, they're pushing 9,000 metric tons of crickets ground up into flour. So it's a little bit of a difference that just say, let's look at the threshold and maybe some insects happen to get into a grain supply versus just a product made strictly for that.
You want to follow up?
Yes, ma'am.
Yes, you
Thank you,
may.
Madam Chair. So again, you're saying it's strictly made from it, but my question is there any difference in the percent? The bar you passed around only has 8%
Yes.
of cricket flour in it. Is there a degree, do we know the percentages of the other things?
I don't know
that are-
how the FDA regulates that as far as like what percentage and when they have to disclose that. You mentioned a couple other products like Cokes and grains and stuff like that. There is a threshold at the FDA, I'm not sure. But the way this bill aims is products that are strictly made from it. With the intent
My
of,
apologies.
yeah, selling it to the consumer.
Thank you.
Thank you.
Thank you.
My pleasure. Delegate Johnson.
Thank you, Madam Chair. So would you consider this more of a public safety bill? Because when you mentioned that people who have shellfish reactions some would have reactions to this, that really concerned me. I know a lot of folks that have a shellfish.
Well, I think it's a big concern. The EU just allowed it regardless of it because they said the tests were inconclusive. It's been reported that many people do have a reaction to like insects that suffer from shellfish allergies. So, I'm just a big fan of knowing what we eat in our food supply. So, and like I said, the bill aims to copy what we already do with imitation crab meat.
Thank you. Any other questions or concerns? See none, thank you, Delegate. Thank you for your testimony. We have an unfavorable from Sarah Price, the Maryland Retailers Association. Good afternoon.
Good afternoon. Thank you. Good afternoon, Madam Chair and honorable members of the committee. My name is Sarah Price, here on behalf of the Maryland Retailers Association in respectful opposition for exactly the reason that the sponsor stated. We have concerns with interstate commerce and labeling. We reviewed this with our members, and generally, everyone is in agreement. Yes, everyone should know what is in the food that they are consuming. Most of our members don't even sell these products and believe that if someone is coming in to purchase them, it is with the intent to seek them out and purchase them. It would be unlikely, I think, that someone would maybe buy it by accident. But ultimately, we do just, we can't really support any policy that would create an individual labeling standard for the state. Packaging is not produced individually for specific states, particularly when you're dealing with national or international brands, like something maybe being made in Canada. They are not going to silo packaging specifically for items sold in Maryland. So we just don't think that that's really operational for any business. If the concern is about maybe items sold in restaurants, like shakes and smoothies, things like that, perhaps this could be solved by like menu labeling rather than the packaging, because that's, if someone is purchasing if you're ordering something at a restaurant or a smoothie bar, you're not going to see the packaging that they're using for the ingredients anyway. So that might be a way to address your concerns, but ultimately, we oppose just based on interstate commerce and labeling. Thank you.
Thank you for your testimony. Any questions for this witness? Can I ask, will you be so kind and meet with the delegate after the hearing, please?
Absolutely.
Thank you. Seeing none, thank you for being with us here. This actually concludes the bill hearing on House Bill 606. Next, we have Delegate Chang, 354, followed by Delegate Fellmark. And welcome to our committee.
And may I bring up my panel?
Absolutely.
Thank you very much, Ms.
You're welcome.
Betty Ann Monley, and also Ms. Kelly Nelson, if you could please join us. Thank you very much, Madam Chairwoman Pena-Melnick, and also Vice Chairwoman Cullison, and also all the members of the Health and Government Operations Committee. My name is Mark Chang, member of the Maryland House Delegates, District 32, and this afternoon I'd like to present to you House Bill 354. It's the ABLE Act, Maryland Achieving a Better Life Experience Program. The Maryland ABLE is a tax-free savings
Delegate Chan, may I
account.
interrupt you for a second? Your witnesses, what are their names?
Sure, it's Betty Ann Monley and also Ms. Kelly Nelson.
They were not signed up to testify. So I'm not able to take
Okay.
the testimony because those are the rules if they have not signed up. However, we in this committee are really generous with the sponsors' time.
Right.
So if you would be so kind and speak for them, that would be great. You do have Rachel London who testified to, on this committee, actually, who signed up to testify as well.
Okay, great. Thank you very much, Madam Chairwoman. Excuse us, and
It's okay.
sorry about the
It happens.
mishap.
And for both of you, I'm sorry that you won't be able to be heard, but we do have the bill in front of us. The delegate is amazing. He's very competent, and we also read all the written testimony. And after the bill hearing, you can email us, and we'll also read what you send us as well, okay? Thank you for understanding.
Thank you very much,
We're so grateful. You
Madam
can
Chairwoman.
stay there with the delegate. That's okay. Go ahead, delegate.
Great. Thank you very much, Madam Chairwoman. Thank you to the gentleladies for being up here today, too, and for their time. The Maryland ABLE is a tax-free savings account for the purpose of covering eligible qualified expenses associated with living with a disability. HB 354 seeks to adopt a federal regulation by the IRS into Maryland statute that clarify the eligible individuals that can establish and operate an ABLE account. The eligible individuals are, first, the eligible individuals themselves. Number two, a person selected by the eligible individual. Three, the eligible individual's agent under a power of attorney, or if the individual does not have a power of attorney in the following order, the eligible individual's conservator or legal guardian, spouse, parent, sibling, grandparent, or represented payee appointed by the Social Security Administration. By aligning Maryland's ABLE Act with federal legislation, the Maryland 529 Board will be able to more clearly establish and operate ABLE accounts and designated beneficiaries. That is my testimony, and thank you for the committee's consideration. We urge a favorable report.
Thank you. Are there any questions for the delegate? So delegate, tell me a little bit about your panels, their experience regarding this bill.
Sure. These are two gentleladies who actually have family members who have the disabilities, and this is a type of a savings account that really helps their families out with different types of expenses. And because of this account, it's really an opportune time for them to be able to save for the future and also to be able to help with regards to long-term expenses. And also, we also have with us the director to my right. She is the director of Maryland ABLE, too.
Okay, wonderful. So we received a letter from the Maryland Department of Human Services. I don't know if you were able to see it, probably not, because sometimes they come in late. But in there, it says House Bill 354 does not provide clarity regarding who may or may not be an additional eligible person to establish an ABLE account. Secondly, local departments of social services and area agencies and aging directors serve per Section 13705 of the States and Trust Article as the public guardian of the person. House Bill 354 will be strengthened by including the clarification that they are not permitted to establish ABLE account. If I may ask you, before we appoint this to the, actually assign it to subcommittee, if you will be so kind and contact the Department of Human Services and work with them on amending the bill so that it addresses their concerns.
Sure, that'd be great. Thank you very much, Madam Chair.
My pleasure, and thank you both for coming. We really appreciate you, and the delegate will work with the Department of Human Services to strengthen it, and then it will go to subcommittee, okay?
Great,
You have
thank
a
you very
blessed
much.
day.
Have a great day.
My pleasure. Rachel London. And delegate, when you get those amendments, make sure the committee gets it. Thank you. And you're welcome to come to the subcommittee as well. Ms. London.
Hi again, Madam Chair, members of the committee, Rachel London, the Executive Director of the DD Council, here today as the Chair of the Developmental Disabilities Coalition, and that's the written testimony you have in front of you. A couple of things to note. This bill really changes Maryland law to align with changes already made at the federal level, right? So two things passed at the federal level, the ABLE Age Adjustment Act, as well as the list of people who can now open an ABLE account. Also want to say that the whole coalition, really appreciated that the Maryland ABLE program reached out to all the stakeholders, convened focus groups before coming up with this list, and a couple of those safeguards you see in the bill, and 98% of all stakeholders that met in these 9 different focus groups were in agreement with this and the list. Also, I just want to say, for anyone's information, if you want more information about ABLE accounts, the DD Council worked with the Maryland ABLE program to publish and create a user guide about the program in plain language, which is available on our website at any time. Happy to share that. For all the reasons that you've heard, for what our testimony says, and because we really do want more people to be able to save for the things that they need and want, the DD Coalition strongly supports this bill. I'd be happy to answer any questions.
Any questions? Delegate Bandari.
Thank you, Madam Chair. Thank you, Delegate Chang, for this very important bill. I'm wondering what specific tax benefits and services does the ABLE program provides to individuals living with disabilities, and how will this bill impact their lives and support their ability to live independently?
So great question. A point of clarity, and I don't want to misspeak, so would have the program answer any questions if I do. The ABLE program already exists in Maryland and has for a long time. You passed this, I believe it was in 2014, 2016. And since then, people have been able to save up to a certain amount that does not count as part of their assets for benefits like Medicaid and Social Security, so that they can maintain those benefits and then use that money that they have in their ABLE account. You can save more when you're working. The limit increases for those qualified disability-related expenses. And that's a larger list, right? That is not just services and supports, but that is all the other things you need in life to live independently and to really thrive and live your best life and do all the things that you want to do as a person with a disability.
Any other questions? Seeing none, will you be so kind and meet with a delegate on the Department of Human Services to try to draft those amendments? Sure. Thank you very much. Thank you both to the delegate and to Ms. London and to the panel for being here. We really appreciate it. You have a blessed day. This actually concludes the bill hearing on House Bill 354. Next, we have House Bill 726. Delegate Fellmark, if you'll be so kind and bring with you your panel, that will be wonderful. Maryland Medical Assistance Program, Autism Waiver, Military Families. And I believe you have Rachel London, Cheryl Chaffers, and and then there's a virtual person, Ms. Nash. Thank you. And good afternoon.
Thank you.
You're welcome.
Do not touch.
You can get started.
Okay. I'm following the instructions to not touch the mic.
Yeah,
There we
it
go.
came
Okay,
on.
we're good. Okay. Thank you. Thank you, Madam Chair, committee members. Good afternoon. For the record, I'm Delegate Jessica Feldmark, here to present House Bill 726, and it is a pleasure to be with the Health and Government Operations Committee for the first time in my career as a delegate, so thank you. This is a pretty straightforward, simple bill. You may hear that a lot. I think it's true this time. As you know, we have, unfortunately, in Maryland, a long waiting list for autism waiver. And, children, families spend years on this waiting list. And this is a particular problem that impacts our military families. Because what has happened is when a military family gets transferred out of the state as part of their military service, the child on the registry loses their spot in the waiting list. And when they return, then have to start over, and that wait is even longer. So this would correct that and say that a child can keep their place on the registry when a family is transferred out of state for military service, and just keep their spot in line. If they become eligible while the family is out of state, they would be eligible when the family returns, whether that's being transferred back by the military or if they're choosing to return as civilians. So that's the essence of the bill, fairly straightforward. I want to particularly thank Cheryl Chaffos, who you're about to hear from, for sharing her story. And it is a tragic story involving much more complex issues. This was one small piece of her story that, even though it's small, it's significant, and it's one we can fix easily, and we should. So I thank you for your time and consideration. I ask for your favorable report, and happy to answer any questions. Go ahead. Okay.
Hi, good afternoon.
Good afternoon.
My name is Cheryl Chaffos. I'm a military wife. My husband served in the U.S. Army on active duty for 30 long years and is a retired colonel of military intelligence. We have 4 boys. One of our boys, Zachary, had autism and passed away unexpectedly in August 2021 at the age of 19 at Shepherd Pratt Hospital. If you would like to read our story, you can Google the Washington Post. Autistic teen spends weeks in ER waiting on a psychiatric bed. So if you Google that, that is our entire story. Zachary was on the autism waiver when we moved to Maryland. We got him put on in the summer of 2003. We were very, very lucky to stay in Maryland. I was able to stabilize my boys for 10 years while my husband deployed to Iraq, Afghanistan, commuted to the Pentagon, commuted to Fort Belvoir, and moved to the Army War College while I stayed behind to stabilize my kids. Even though we moved back to Fort Meade in 2015, so we left Fort Meade in 2013, we moved to Texas for 2 years. Zachary was removed from the autism waiver. We moved back in 2015, and he never came off the wait list, nor was Zachary able to utilize any funding provided under the autism waiver. Again, until Zachary's death, we didn't attain any of the support that we were hoping to get with the autism waiver. And I can tell you, for military children, it's imperative that we access some of the funding for the autism waiver to get in-home supports and other services available. For example, respite care. I never was able to get respite care for my family, despite my husband being deployed multiple times. I'm asking the House members to overwhelmingly support and approve this bill for one of our most vulnerable populations, autistic children of military parents. We do not want to suffer or lose services due to their parents' service to our country. Please honor Zachary and help others through your support with this legislation. Thank you so much. Sorry for going over.
No, were you finished?
Yes.
Okay, you could have taken your time, don't worry. And thank you so much for sharing your story. I remember reading it, actually, and it really, really touched my heart. And this committee has been working really hard at trying to find beds for these very tough-to-place kids as well. So it's one of our priorities in the Appropriations Committee. And I want to say I'm so sorry for your loss. And
Thank you.
And thank you for coming and sharing your story. We really appreciate it, okay?
Thank you very much.
Next.
Madam Chair, members of the committee, for the record, Rachel London with the Developmental Disability Council. Again, this is my last time today. You have written testimony from the
keep it
council
up.
and the ARC Maryland in front of you.
I said, you keep it up and you're going to owe us dinner.
I just want to highlight a couple of things. So as the executive director of the council, I sit on a variety of advisory councils and work groups specific to the autism waiver, and there are in fact 6,600 children waiting for services on the registry as of this month, and about 1,524 actually receiving those services. And we know that families wait an average of 9 years once they get on the registry. I have also, in the last couple more months, worked very closely with a variety of service members and veterans as part of the governor and the lieutenant governor's transition team. So we also know there's about 50,000 active duty and reserve members of the military here in Maryland, and those active duty and reserve members have over 46,000 children. Right, and we know the statistics on children with autism, about 1 in 44. In recognition of the need for these services, Maryland already requires other waiver programs, like those operated by the Developmental Disabilities Administration, to allow dependents of military families, so that's children and adults in this case, to remain on the waiting list for services while a family moves out of the state for service. It also requires that DDA reinstate services when someone's eligible. So we do this already. So for all of those reasons, we strongly support this bill. It does the same thing for children of military families, and it really, the bottom line is it relieves one more stressor. Thank you, Madam Chair.
Thank you for your testimony today. Are there any questions for this panel? Yes, Delegate Riley.
Madam Chair, yeah, Delegate Felmark, did you mention that the Senate passed this already 45-0?
I neglected to mention that, but it is true. It is true, yes. So,
Thank you.
Glad to see their unanimous support, and I certainly hope the House will follow suit.
That will make your bill easy, just like Delegate Kaiser's bill. Anyway, we do have, thank you, Delegate Riley, that was a very good question. We do have a virtual witness. It is Ms. Lynn Nash. Will you be so kind and get started? And good afternoon. Welcome to our committee.
Thank you so much. So I'm Lynn Nash. I'm a retired captain from the United States Public Service and Army, and I'm representing the Maryland Military Coalition, which is a group of 19 organizations that advocate. So to Delegate Feldmark's comments, the average military family right now is moving every 2 to 3 years. And when you knock a kid off the list, and they come back, because in the Department of Defense, we have military hub hospitals, which are the larger ones that have all of the specialty services that these kids need. So it's not often for the same family to come back to our state 3, 4, 5 or more times. So it makes absolutely no sense to knock it off the register. We know that kids with autism need a very stable environment. And Mom, you said that. Thank you. The only way that you can do that is to have critical services all the time. So our coalition, which is a voluntary nonprofit organization, we represent about 150,000 veterans here in Maryland. We totally support the bill and ask for your favorable report. Thank you so much, Delegate Feldman, for putting this in. Our families really appreciate it. Thank you.
Thank you for being here, Ms. Nash, and thank you for your service. Are there any questions for this panel? Seeing none, thank you so much for being with us today. We really appreciate it. You have a blessed day. Thank you again for sharing your story. This actually concludes the bill hearing on House Bill 726. Next, we have House Bill 703, Delegate Kerr, Public Health, Parkinson's Disease Registry Establishment. Will you be so kind and bring your panel? And as soon as you sit, will you get started? Thank you so much. And I believe you have our friend Larry, Bill Pitcher, Julia Pitcher. How are you, Julia? Long
It's
time
so
no
good to
see.
see you.
Great to be seen. Good afternoon, Delegate.
Good afternoon, Madam Chair, members of the committee. I'm Delegate Ken Kerr here today presenting HB 703, Parkinson's Disease Registry Establishment. Parkinson's disease, or PD, is a long-term degenerative disorder of the central nervous system that affects mainly the motor systems. The symptoms emerge slowly, usually after age 50. And interestingly, Parkinson's disease is more common in men. The most obvious early symptoms are tremor, rigidity, slowness of movement, difficulty with walking. Cognitive and behavioral problems may also occur. Depression, anxiety, apathy, and as the disease worsens, non-motor symptoms become more common, such as dementia, Alzheimer's, and inability to swallow, as well as hallucinations and delusions in some cases. There's no treatment to slow, stop, or reverse the progression of Parkinson's disease, and there is no cure. We don't really know what causes it. Inherited and environmental factors are believed to play a role. Those with affected family members tend to be at higher risk. Other risk factors include exposure to certain pesticides and previous head injury. A 2022 study co-funded by the Michael J. Fox Foundation and the Parkinson's Foundation showed that there are 90,000 new cases diagnosed each year. While the federal government spends $280 billion treating Parkinson's patients, it spends only $180 million. That's $280 billion to treat, $180 million spent on research. By comparison, Alzheimer's research is $3.7 billion, funded by the NIH annually. So HB 703 will establish a statewide Parkinson's disease registry through the state's Health Information Exchange, CRISP, that will ultimately disseminate relevant population data from patients living with the disease and to send that off to CDC's National Research Database. Following the creation, this research registry will collect and provide de-identified patient information upon diagnosis to the Maryland Department of Health to further CDC research in planning healthcare requirements and for educating healthcare providers. The research registry will ultimately provide researchers across the country with the best possible chance to use this data and the prevalence patterns towards finding a cure for this progressive chronic disease experienced by over 1 million Americans, including 110,000 military families. Comparing Maryland to other states that have established Parkinson's registries, we would estimate the cost of establishing this to be about $250,000. The data collected can reveal patterns in the disease, possibly leading to prevention, as well as assist the state in healthcare planning for those suffering from Parkinson's. And I request a favorable committee vote on House Bill 703.
Thank you for your testimony. Who will be next?
I think I'll be going next.
Thank you.
Thank you all. Good afternoon. My name is Julia Pitcher, and I'm the head of U.S. State Government Relations for the Michael J. Fox Foundation for Parkinson's Research. It is so wonderful to be back with so many familiar faces and many new faces in this room. The Michael J. Fox Foundation for Parkinson's Research, also known as MJFF, was founded in the year 2000 and has been singularly dedicated to finding a cure for Parkinson's disease through aggressively funded research agenda and ensuring the development of improved therapies for those living with PD today. And since then, as you heard about how little the federal government actually invests, in the 22 years that we have been in existence, the Michael J. Fox Foundation has funded $1.5 billion in research around the globe. And one of the reasons that we're here today is for these Parkinson's registries. The reason that they are so important is that registries, and this is not just a regular registry to just collect information and leave it somewhere in the state. It is to continue the work and send that data up to the CDC's National Neurological Conditions Surveillance System, otherwise known as NNCSS. And the CDC is not empowered to go tell states, now go pass laws and go put this data into effect for researchers. So we, at the Fox Foundation, have decided to go across the country and get more of the states uploaded and live with these registries. There are currently 2 functional registries in the states, California and Utah, and we are currently in 9 states in the year 2023, from Hawaii to Oregon to Ohio and Maryland and New York and Massachusetts and a few in the middle as well, where we're looking at these bills. From there, our goal is to then go back to the CDC, flip the light switch, and have that patient data pulled and put into one giant research hub so that researchers can do more qualitative and better substantive pattern research, such as what Delegate Kerr said about chemical exposure, patterns in certain areas. There's known as the Rust Belt, as well as Parkinson's Row in California and other areas of the country that we are seeing an increase. And with that, I will just say thank you for having us. We do have lots of questions about the fiscal note, as there will be sponsor amendments that are coming forward, and I'm here to answer any questions. Thank you so much.
Thank you. Good afternoon, Larry.
Good afternoon, Madam Chair, and all the members of the Health Government Operations Committee. My name is Larry Zarzaki, and I'm a healthcare advocate for AARP, and I'm a Parkinson's patient. And I'm going to try to get through this as quickly as I can.
You can take your time, Larry. Even if you hear the sound, don't worry about it, okay?
Thank you. Thank you, Madam Chair. House Bill 703 establishes a Parkinson's disease registry and advisory committee. What it will do is it will create a system for collecting data and information for dissemination of information determining the incidence and prevalence of Parkinson's disease. An individual with Parkinson's may opt out. And I think that's very important because a lot of people don't want their information public. The registry will be housed in the Maryland Department of Health. And I am speaking as loudly as I can, so please bear with me.
We can hear you, and take your time, don't worry.
Parkinson's disease is a chronic, degenerative disease that there's no cure for. The registry is a database that will be utilized for research, for planning healthcare requirements, education of healthcare providers. And if this bill is passed, it will create a Parkinson's disease registry that will collect information about the disease and will be used by researchers to find pardon me.
It's okay. Don't worry about the bill.
If enacted, researchers could use that data to identify patterns, look at trends across the population, diverse in race, ethnicity, socioeconomic status, and history of exposure to occupational and environmental toxins to help Marylanders who have Parkinson's disease. For these reasons, we would respectfully ask the committee for a favorable report for House Bill 703. And if I may very quickly,
sure.
I would like everybody to just think for 1 minute what it would be like. And my Parkinson's is, I'm starting to lose my legs, and I can still ride a bicycle and use a Versa climber. It has affected me cognitively, as well as physically. So I'd like for you, each of you, to take a minute and imagine what it must be like to have to go to the hospital to have a carrot removed from your lung because you're losing the ability to swallow, or to have holes drilled in your head. But more importantly, there's so many people out here that are misdiagnosed, and this registry is very important to the education of the neurologists and other medical professionals. I'd like to thank Delegate Kerr for championing this bill, and I'd like to thank each and every one of you for your patience. And if Delegate Shalega and Guzon, if you feel like you have a spring in your step, please pass some of that cricket powder my way. Thank you very much.
Thank you, Larry. You know, I know you for so many years, and we really appreciate your sharing your story and the time you take, which it takes a lot of effort to be here. So thank you very much. We really appreciate you.
Thank you, Madam Chair.
My pleasure. Mr. Pitcher.
Thank you, Madam Chair. Members of the committee. I guess it's on. Can you hear me now?
Yes.
Bill Pitcher, I'm here on behalf of the Michael J. Fox Foundation. I am their local legislative and legal counsel, and as most legal counsel jobs are, we got to come in last and try to clean up a couple of loose ends. Let me just give you a very quick summary so that you can put this in context. Last year, Delegate Kerr and others sponsored legislation to do what we're talking about here, a registry. And Larry was here in support then, and glad you're here again. The bill came out to be an advisory committee which met over the course of this past summer. They didn't implement, you didn't implement the whole bill. There were a lot of questions. There was a fiscal note that was a little higher than we thought, and so we addressed all of that this summer. And during the course of this interim, a stakeholders group on this advisory committee from all the various stakeholders came together and discussed how are we going to do this without it costing the state, if you look at today's fiscal note, it's over $1 million. We didn't think that that was correct. Julia's experience in other states shows that it's not as correct. I mean, that's more than they do in California. So we figured that Maryland might be a little cheaper than California to do this. They came up with a marvelous idea, and it was supported by the people that have volunteered to do this data collection. Instead of the department doing it, incurring a fiscal note to the state, we will have CRISP, the health insurance organization, do it, and they will take on those costs and responsibilities. It didn't make it into the bill drafting, unfortunately. The bill was drafted as before with the department. What we are hoping to do, and we already have drafted up amendments with the sponsor to put this in CRISP and not in the department. CRISP will coordinate with the department, and hopefully it's a win-win for everybody. Let's do something good.
Thank you. Did CRISP agree to do it?
Yes.
They have?
Yes.
Okay.
And there should be a report from the department stating that from all the stakeholders, including Chris, but due to the transition in administration and other backlogs, it just wasn't ready in time for today.
Okay. Great. Delegate Shalega.
Thank you, Madam Chair. Thank you for being here. Nice to have a father-daughter team here batting at the table. So I noticed the fiscal note said 3 positions in the Department of Health, and CRISP, what have you seen in California, other places where they're doing this? How many positions do they need? And, you know, give us a little bit of information on how the fiscal note will be different.
Thank you, Delia. That's a great question because the California bill was passed in 2017 and was housed in the department, and they did hire 2 staff, one director of administration and programming of it, and then an IT person to build it and they will come. And that's where they started. And they started with $3.4 million over 4 years. So it's a little under $1 million per year to build it. Again, that was in 2017. And since then, we have learned that there are other options through State Health Information Exchange, or HIEs, to do this, which is what we're doing. It's brand new. So we do not have other states already have one in effect. But in Nebraska and Ohio and Maryland and New York and Massachusetts, where my bills are going right now, this is the model where we're going to have the data that's already collected through CRISP. Everybody is in participation of that. Your information comes through your primary care or your neurologist, wherever your diagnostic code comes through, the ICD-10 codes will be already collected by CRISP, aggregated, de-identified, and sent to the department. So the department does not actually have to do the build it piece at all. The building has already been built. It's in CRISP. CRISP will take the information, send it to the department. The department will publish a yearly report for the public and for the state to see incidence and prevalence numbers of Parkinson's in the state of Maryland. And then as we get more states online, we will be able to flip that information to the CDC's program, and then that will be accessed by researchers around the globe for better research. So that is why it's a timeliness factor. We want to do these quicker, because this is the second fastest growing disease after Alzheimer's, with 90,000 per year. So that's how the logistics will work, and that's why the fiscal note is somewhat irrelevant until we get the reprint finished, and then there will be a revised note. So hopefully that answers your question. Thank you.
Delegate Lopez.
Thank you, Madam Chair. My question is for Ms. Pitcher. Yes. You mentioned that I have you down as favorable with amendments, and you mentioned the amendment. Can you just explain it a little bit in more detail? I just want to make sure I understand it.
Sure. When I signed up as favorable amendments, I forgot that I was with the sponsors panel, so thank you for clarifying that. The amendments are sponsor amendments, and they are being drafted right now, and what they are going to do is everywhere you see department, it's going to come out and it's going to state the state, I'll give you the exact, State Commission on Health Equity, the State Designated Health Information Exchange will use the data set maintained under paragraph 2 of the subsection to improve health outcomes for patients. So that will be the main clause that will take the data and then send it to the department. So there's no building of that, and that's what you all should get that any minute now from the amendment office to see that. You're welcome. Thank you.
Just for clarification, the Maryland Department of Health will still have to house it, correct? What is the role left for the Maryland Department of Health?
They will house the data that they are given and then publish it. That's all they have to do. They don't have to collect it or organize it or clean it or de-identify it. They won't have to do any of that.
Okay, but there still will be a cost to that.
There may be a small cost, yes.
Right.
So.
Can you please continue those conversations with them?
You bet.
Thank you. Delegate
Thank you, Madam Chair.
Madam Chair, just one quick question for clarification. You mentioned the ICD-10 codes. Are the ICD and the DSM-5 parallel? Are they the same, basically? And would it have any impact if there was a difference between DSM and ICD-10?
I love that you mentioned that. Thank you so much for that question. It will be whatever is the most accurate and new for each state. There will be there's usually a primary, and I don't have the numbers off the top of my head, my apologies for that. There's a main Parkinson's diagnostic code, and then there are Parkinsonisms codes or Lewy body or other dementia codes that would be subsets of those, and those will also be included so that we're not excluding those that may have a derivative of the main Parkinson code. You're welcome. Thank you.
And for the benefit of the committee, tell them what that stands for, the DSM.
Diagnostic Statistical Manual.
And can you tell the committee what that is used for?
It's used for diagnostic codes for all medical diagnoses and their derivatives from there. I am not a medical professional. I am just a lawyer.
How often is it published?
Every 5 years?
Yeah, something like that, yeah.
Oh, you were hazing me today, Madam Chair.
That's
Thank
okay.
you.
I just want to make sure that the committee knows. It's okay. You can ask the question. Go ahead, ask the question.
What's ICD, though? I know DSM-5, but I don't know what ICD is.
I'm so sorry, I don't remember that one.
Is it a comparable?
It's the diagnostic codes that's used through insurance carriers and beyond, and I know there are people behind me who can explain this more, but it's whenever you have any diagnosis, whether it's flu, cold, COVID, depression, manic disorders, et cetera. It's the terminology that has a number that's attached to it for reimbursement and then other information exchange coding.
And if you can give that information afterwards, and Delegate Taveras, Delegate Woods is very familiar, you can speak to her offline.
Yes, and it's not just a Maryland thing, it's a national, it goes with Medicare and Medicaid services as well, so.
Thank you.
If I may, the coding that differentiates Parkinson's from a Parkinsonism, Parkinson's coding is a G20, and Parkinsonism is G90, and that's how it's differentiated. A Parkinsonism is something that mimics Parkinson's. It can be drug-induced, so it can be many different things. CRISP is set up to differentiate that. So I believe, as Ms. Pritchard was saying, that CRISP is pretty on top of this and already has the templates laid out. And it will be very straightforward and very cost-effective.
Thank you. Thank you so much. Seeing no other questions, thank you for your testimony today. We really appreciate you.
Thank you.
And this, our pleasure. Thank you, Larry. This actually
ma'am.
concludes the bill hearing on House Bill 703. Next, we have House Bill 716, Delegate Gazzoni, Managed Care Organizations, an acknowledgement of responsibility for payment of a retroactive denial, repeal of applicability. If you have a panel, will you be so kind and bring them with you? And I believe you have Annie Coble, Jennifer Bremen, and Dana Kaufman.
And Kathleen.
And Kathleen. And you can get started. Good afternoon.
Thank you. Good afternoon, Madam Chair and members of the Health and Government Operations Committee. I'm Delegate Pam Gazzoni, representing Howard County's District 13, and I'm here in support of House Bill 716. I want to start off by saying that I will be submitting amendments to this bill, which have been worked out with the advocates and will also be reflected in the Senate cross-file, which was heard in the Senate Finance Committee last week. These amendments address concerns raised, but more importantly, I think they significantly clarify the objectives of the bill and the improvements the bill makes to the coordination of benefits process. The purpose of this bill is to alter the information that must be included in a written statement provided by a managed care organization to a healthcare provider when retroactively denying reimbursement as the result of coordination of benefits. Managed care organizations, or MCOs, are the carriers for Medicaid recipients, and of course, Medicaid is the payer of last resort. Therefore, MCOs will retroactively deny reimbursement when it is determined that the member is also covered by a commercial carrier. Currently, it is only when the private payer acknowledges the claim obligation that the MCO can recoup its costs on coordination of benefit grounds. This is a high bar and one that the Department of Health has confirmed with CMS goes beyond the requirements of federal regulations, and that's noted in the letter from the Department of Health that's in the file. The bill makes clear that for a retroactive denial, the MCO needs only to provide a written statement to the provider with the name and address of the responsible commercial carrier. Because this bill will prevent state dollars from erroneously being spent on claims that should be covered by private carriers and thereby reduce inappropriate spending of the state's Medicare funds, it is being submitted as an emergency bill. I appreciate the efforts of the advocates to come together and reach consensus on the amendments, and I respectfully request a favorable report on HB 716. Thank you.
Thank you, Delegate. Who would you like to go next?
Good afternoon, Madam Chair, members of the committee. I'm Jennifer Bremen, Executive Director of the Maryland Managed Care Organization Association. Thanks for your time today. I'd like to thank the bill's sponsor for carrying this bill for us this year. This is a really important bill for the MCOs. The Maryland Managed Care Organization Association represents the 9 MCOs that serve Maryland's Health Choice program. The MCOs serve over 1.5 million Marylanders that are enrolled in Maryland's Medicaid Health Choice program. That's roughly 1 in 4 Marylanders that have their health care coverage through an MCO. All 9 MCOs serving Maryland's Health Choice Program strongly support the passage of this legislation. The MCOs that serve Maryland Medicaid are committed to identifying ways to improve access to quality health care for all Medicaid participants, and they are also committed to identifying efficiencies to improve the Medicaid program through cost savings potential to the state. We believe that this bill does have a great cost savings potential to the states through the bill's provisions, and for that reason, we strongly support the bill's passage. My colleague and the GR committee chair of the association, Kathleen Loughran of Wellpoint, Maryland, will speak to the bill's provisions in detail. But we strongly support the bill's passage, and I would like to thank you for your attention today.
Who will be next?
Thank you, Madam Chair, committee members. Kathleen Loughran. As Jennifer mentioned, I am the legislative chair for the Maryland Association of MCOs. I am also with Wellpoint, formerly known as AmeriGroup. We are the second largest MCO in the state of Maryland, serving the state statewide. We've been here since the inception of the program. I want to take a minute to thank our sponsor, Delegate Gazzoni. She has done an admirable job of leading this effort and working through the issues with us. Her testimony was spot on, so I don't have a lot more to add. I will give you a little bit of detail behind why this bill is here today and the clarification that's necessary. There has been a provision in law for many, many, many years that was never recognized or utilized in such a way until last year, when the insurance commissioner determined that an MCO could not retroactively deny payment, even if a commercial carrier was responsible for the payment, unless that carrier provided written acknowledgement of responsibility. So that meant that we somehow had to get that carrier to acknowledge in writing the responsibility that they may have for the claim. We are here today simply to remove that piece of the law so that an MCO does not find itself in a position of trying to get a written statement of acknowledgement of responsibility from a carrier that we don't have any authority over. And the amendments that will be coming in on this bill and have been worked out on the Senate side, they had their hearing last week, simply clarifies for the benefit of the provider community that we will still provide the name and address of the entity that we have come to know is responsible or may be responsible. But they will get the name and address of that entity. We simply are not acknowledging responsibility by the other carrier. And I will just add that many times we're getting information about a private carrier's responsibility from the Department of Health itself. And that is what allows us to have the coordination of benefits and ensure that the state of Maryland, if they are audited by CMS, or frankly, if we are audited by MDH, do not find that there are monies that could have been recovered and should not have been paid by the state of Maryland. And I'm happy to answer any questions, but at this time, let me turn it over to my colleague, Annie Coble.
Good afternoon, Madam Chair and members of the Health Government Operations Committee. My name is Annie Coble, and I'm here on behalf of Priority Partners as a member of the MCO Association to express our support for HB 716. Priority Partners is a managed care organization jointly owned by Johns Hopkins Healthcare and Maryland Community Health System. It is the largest MCO in the state with over 360,000 members. We support this bill and its intent to ensure Medicaid is the payer of last resort as is required by federal law. Without this bill, there is a real risk of the state inappropriately paying claims through Medicaid that a commercial carrier should be paying. Therefore, to protect Medicaid funds and ensure that it remains the payer of last resort, we urge a favorable report on HB 716.
Thank you. Next.
Madam Chair, members of the committee, my name is Dana Kaufman. I'm here on behalf of MedChi. We initially raised concerns in the Senate Finance Committee regarding this bill. I appreciate my fellow panelists who were very willing to sit down and work this out. We support the clarifying amendment, which basically we just wanted to make sure that the providers, given that this is a retroactive denial, weren't left pretty much holding the bag with no place to go. So we understand their concerns. The amendment will, again, give us that information so that we can go and properly bill for the services provided. And with the amendment, we urge a favorable vote, and I wish all my bills could be worked out this easily.
You have a great sponsor. She did a great job. Are there any questions for the sponsor and her panel? Seeing none, thank you very much for your hard work, Delegate.
Thank you.
Take care. This actually concludes the bill hearing on House Bill 716. Next, we have House Bill 333, Delegate Charkoudian, Hospitals, Financial Assistance, Medical Reimbursement Process. You do have a panel. You have Marceline White, Lorraine Aricott, Ashley Black, Nicole Stallings. Will you be so kind and come up with a delegate?
Yes, thank you.
And as soon as you sit, if you could get started, that would be wonderful.
Absolutely.
Thank you. Good afternoon.
Good afternoon, Madam Chair. Madam Vice Chair is not well. Members of the committee, colleagues. For the record, Delegate Lori Charkoudian here asking for a favorable report on House Bill 333. Many of you are maybe familiar with the history of this bill, and since so many of you are new, I'll give you a little bit of the background. You're probably familiar with the fact that we have been working for a number of years on the issue of medical debt, broadly on the issue of medical debt in terms of people getting sick and then ending up in debt and then ending up destitute as a result of that debt. It is a national problem. Over the last several years, we've worked on policies to improve the way that we do our financial assistance program and to improve what is and isn't acceptable in terms of guardrails on how medical debt is collected. And we've made a great deal of progress. And in fact, Delegate Lewis's bill in 2020 made progress on the financial assistance program and also required that HSCRC do a report analyzing a number of things. And this is the cover of that report. The report should be in my testimony. If it's not, I'll get it to you if you're interested in reading it. But there's a couple of really important things that this report found. One of the really important things that this report found was in its analysis of the individuals who the hospitals who should have been screened for and received free medical care, who were eligible based on all the systems that we have in place. This report basically pointed to the fact that 60% of them did not receive that care, and in fact, 59% of them were pursued for debt, and then that debt was written off. But 1% of them actually received those bills even though they should have received free care, and paid those bills. And that payment to the tune of $60 million, there's a lot of 60s somehow in this report, but bear with me, $60 million in 2017 and $60 million in 2018. And so we have reason to believe that until our new policies went into place in about 2022, that individuals who were eligible for free care probably went through the process, didn't get screened, got bills, and paid those bills. And so now we have tighter processes in place to make sure that people who are eligible for free care get that free care, but we need to make sure that the people who paid those bills are made whole. This has been a somewhat complicated process to figure out the best way to make them whole, how to identify them, how to protect people's personal information, and then how to make sure that that money gets back to them. There's been a really, I'm grateful for the work of what many stakeholders have put into this. The Maryland Hospital Association has worked, HSCRC, many of the advocates that you're going to hear from. Many of the state agencies. Last year we passed a bill to move this process along, but HSCRC worked with all the stakeholders in the interim and identified a couple of different changes that we need to make to state law to allow for the data sharing, which will allow for the identification of these patients and will allow for the repayment. And so this is sort of hopefully one last time that we're working on this issue. We expect that if this bill passes, and I hope it does, that this money will get paid back to these individuals. This money could be anywhere from $100 to $1,000. As you know, people who are struggling to pay their bills, any amount within there could be really meaningful. And that then we'll be moving forward with the stronger protections that we have for people, making sure people eligible for financial assistance get it, and with the protections we have on medical debt collection. Asking for a favorable report, and happy to take questions after other members of the panel speak.
Thank you. Thank you for your work. We have, who would like to be next?
Chair Minutes?
Marceline White?
Do you want to go next?
Okay. Okay.
Is it on? Oh.
Do not touch it.
Sorry.
Thank you.
Good afternoon, Chair Pena-Melnick, members of the committee. My name is Marceline White. I'm the Executive Director of Economic Action Maryland. We had a rebrand. And Economic Action Maryland advances economic rights and equity through research, education, advocacy, and direct service. We're happy to be here today, and we're here in strong support of House Bill 333, and I want to thank Delegate Charkoudian for all of her work on this bill. I just want to take a second to tell you a little bit about what the bill is going to do and why it's so important. As Delegate Charkoudian mentioned, the committee unanimously passed legislation last year requiring hospitals to identify, notify, and make patients whole. And the whole House passed that bill by 115 to 2. This bill simply establishes the process that we needed to make that happen. It essentially makes sure that we can repay patients and that we can protect patients' privacy. It makes good in how we are going to share data between the state agencies, and make sure that whenever possible, the notice is sent to a safe address to address concerns that domestic violence advocates had last year. The Health Services Cost Review Commission facilitated a work group over a 6-month period, and I want to thank Megan and the HSCRC as well as MHA and the hospital systems for all coming together to identify a process, and I was part of that group. I want to just mention that medical debt is so important because it's not something you choose. It's not like you run up your credit card for any other reason. You're there for an emergency. It's also something that can really damage your credit reports. If you have medical debt on your credit, there are strong consumer issues, and that may mean that you're limited in access to certain employment, access to certain kind of rental housing, and other kinds of problems because this is parked on your credit. And we also know that medical debt can deter people from seeking other care. That's documented in polling we did in the past year. And so for all of these reasons, we are very thankful that we've come together with a number of stakeholders to identify the process to make sure this happens. And for all those reasons, I am here in strong support of HB 333, ask for a favorable report, and I'm happy to answer questions.
Thank you. Who's next?
I can go. Thank you, Chair Pena-Melnick and members of the Health Government Operations Committee. My name is Lorraine Aricad. I'm the Senior Policy Analyst with 1199 SCIU, United Healthcare Workers East. We are the largest healthcare workers union in the country with over 10,000 members here in Maryland and DC. 1199 is also a founding member of the End Medical Debt Coalition. Our union supports HB 333 and supports amendments proposed by the Attorney General's office to ensure enforcement of the bill. Last year, we passed legislation to form a work group led by Health Services Cost Review Commission, and the research lead from 1199 SEIU was a part of that work group, and we worked collaboratively with work group members and are proud of the result of that work, which resulted in HB 333. I know that people who have medical debt and trouble paying medical bills are more likely to have health issues because of the financial shock and household debt that impacts economic stability, mental health, and the limited access to neighborhoods with built environments that foster good health. It has a domino effect. Some who have been denied access to hospitals, doctors, or other providers because of unpaid bills have an even greater share, but also they put off care because of that cost. One of our members who works as a dietary aide had diabetes and could not afford expensive medication or the treatment needed to address her health needs. Due to fear of the financial distress treating that chronic disease that would cause on her family, she delayed treating diabetes, which caused serious complications that put her out of work. The burden of medical debt is not only felt by the person, but it's felt by the entire healthcare system, the communities, and it has a generational impact. Our 1199 SEIU members who are enduring an ongoing staffing crisis understand deeply how medical debt crisis puts an additional strain on the hospital healthcare workforce. It keeps the sick away from care and piles toxic stress on patients when they're at their most vulnerable, which only leads to more serious emergent health issues overburdening our hospitals. HB 333 is about lifting the heavy financial burden on low-income families, and for those reasons, we urge a favorable report.
Thank you for your testimony. Who's next?
All right, good afternoon, committee members. My name is Ashley Black. I'm the lead attorney for the Health and Benefits Equity Project at the Public Justice Center. We strongly support House Bill 333 as a necessary step in refunding hospital patients who qualified for charity care and were wrongfully charged by nonprofit hospitals. House Bill 333 is a technical fix to legislation that this committee passed last year and is now law. We thank this committee and the stakeholders like HSCRC, Maryland's hospitals, and domestic violence and patients' rights advocates who met in the interim to work through data sharing and patient notification concerns. Collaboration between Maryland's hospitals, the Comptroller's Office, and DHS is essential to identifying every Marylander who should have received free care between 2017 and 2021 but paid their bill. House Bill 333 would also allow those entities to collaborate in carrying out the refund process smoothly without violating existing patients' rights laws, patients' privacy laws. We cannot finish the work that we set out to do last year without this legislation. For many of the patients and families who were wrongfully billed, trying to pay a hospital bill that they never should have received may have been financially devastating and put them in a position of having to go without basic needs. When we think of social determinants of health, we typically think of food and nutrition, housing, transportation access, and other environmental conditions. But growing research is showing that medical debt can worsen social determinants of health by making it harder for a household to achieve financial stability. And for low-income patients, it can also have a chilling effect on them seeking medical care in the future. And this can exacerbate health inequities, especially between different socioeconomic statuses, genders, and races. Charity care is an important tool in addressing health inequities in different communities and help us in building a healthier Maryland. Simply put, this bill allows us to support hospitals in ensuring that they are meeting their obligations to provide charity care. Thank you, and we urge a favorable report.
Thank you. Excellent timing there. Really appreciate it. You do have one more witness on your panel, and that's Nicole Stallings.
Thank you, Marcella. Thank you.
Good afternoon.
Good afternoon. Thank you, Madam Chair, members of the committee. For the record, Nicole Stallings, Executive Vice President of the Maryland Hospital Association, here in support of House Bill 333. I want to thank the sponsor for her introduction of the bill and the acknowledgement of the many years' worth of work that have really established Maryland as a national leader here. Our 60 hospitals and their teams work day in and day out to provide the best care possible, and a component of that mission means ensuring that people can receive the care they need without financial worry or hardship. In our attachment, we've outlined how our hospitals communicate the availability of financial assistance to all patients, multiple touches that start with admission and go months after discharge. But that process is not perfect. Hospitals rely on patients to share information to deem them eligible for free or reduced cost care. Now, through the process outlined in this bill, our hospitals are able to work with other state agencies that have the data that we are missing. The work group deliberated on the privacy and operational challenges that are inherent with the sharing of financial and health data across multiple agencies. State and federal restrictions will impact how this bill is implemented, but we will actively engage with the HSCRC over the interim to further develop the specifications for data collection, data sharing, and patient communication. If you look at the HSCRC's testimony, they have a flow chart at the end, and it looks pretty complicated, and the sponsor noted the complications. This is complicated, and the option that we chose is the most administratively burdensome for our hospitals, but we agreed to that option because we are a partner in this work. So let me close by restating that if a patient was billed for services when they were eligible for free care, that was done unknowingly. If a patient paid a bill that they should not have received, they will be refunded. This bill will facilitate data sharing necessary to identify these patients. And I want to thank the sponsor and all of the stakeholders for the work to have us all here together at the table. We urge a favorable report. Thank you.
Thank you for your testimony today. Are there any questions for the sponsor and her panel?
Delegate Taveras.
Thank you. Thank you so much. I want to say to Delegate Charcutia, you always have the sexy bills, so thank you. This is something that was definitely very needed, and I applaud you for it. My question to Ms. Darling is, I know you alluded to this, but my question is, how could something like this have happened, right? And particularly, do we know if there was a language barrier in a lot of these cases where where we had people that could have been helped, but just for a simple reason that we couldn't communicate effectively with them, that they weren't helped?
I think that the action that this body has taken over the past several years have really strengthened what were already robust requirements. The legislation from Delegate Lewis and certainly the bills from the sponsor have ensured that we are communicating earlier and often. To your question specifically about language barriers, we don't know. I think part of this process will allow our hospitals to understand what went wrong when we identify these patients and maybe do a deeper dive. And we will engage our members throughout this process to ensure that we're sharing those lessons learned.
Follow up real quick. If you could take that data down as part of this process so that we could better understand, that would be helpful.
Thank you, Delegate.
Thank you.
Any other questions? Thank you. I don't see any. I do have one for the delegate. I did see the 5-page letter from the Maryland Services Cost Review Commission. Their last paragraph on page 5 still expresses concerns regarding the data and privacy. I like if, we're going to get in touch with, I see Megan here, they didn't sign up to testify. If you would, continue to talk about that paragraph and see how we can address that before the bill goes to subcommittee.
Do you want to?
Is it addressing your amendments?
What's that?
Is it addressing your amendments?
I am happy to continue to work with them. I guess I'm not.
She's shaking her head that she's willing to sit down with you. Can you do that afterwards?
This is the.
Okay?
Okay.
You don't have to deal with it now, but if you will be so kind, after the hearing, get, in touch with her. She's shaking her head that she wants to sit down. That would be great. Okay?
Thank you.
Any other questions? Delegate Martinez.
President. Thank you, Madam Chair. I had a question for the panel. Looking at the bill, there's not a timeline established on when repayment would happen. So is that something that is already negotiated or talked about? I just didn't see it. If it is there, if you could indicate it to me, that would be great.
Thank you for that question. I'm fairly certain that we have timelines in here. Thank you. I think that we do, but.
You can give it to the delegate offline.
Yeah, it's an extension of, we actually had a timeline last year in here of when it had to be done, and I think we extended it by another year. So I can't find it right now, but I'll make sure to get it to you. But I know we do have a timeline in here somewhere. Yeah.
That would be great. So if you can get back to us regarding those two issues, okay?
Will do.
Thank you very much. Seeing no other question, thank you for being with us. We do have a favorable with amendment. We have a Heather Forsyth.
Good afternoon, Madam Chair and members of the committee. Thank you for having me. My name is Heather Forsyth. I am the Deputy Director of the Health Education and Advocacy Unit at the Office of the Attorney General, and here testifying on behalf of our office in support of HB 333 with the sponsor-approved amendments. It was hospital-submitted data that showed us this problem, that revealed the problem in a report to HSCRC. And what it revealed was problems in the delivery of financial assistance to, as required by statute, to patients who have income under the 200% of the federal poverty level. And this bill attempts to correct at least some of those problems by proposing a streamlined process for getting reimbursements to patients who may have paid for services between 2017 and 2021 when they were eligible for free care. And this process came from a very diverse work group of engaged stakeholders, including the HSCRC and the Maryland Hospital Association, and we believe it presents the most straightforward option for low-income families. You've heard some testimony that it is perhaps administratively complex. The data flow involves multiple agencies, and there is some concern about data flow and privacy, and I would suggest that that's difficult but not impossible, and we shouldn't let that stop us from presenting this most straightforward option for the families themselves. Low-income families would otherwise have pretty significant hurdles to recreating and presenting the financial circumstances that they had 2 to 5 years ago. So this process makes it much easier for them. At the HEAU, we are often helping low-income patients who are struggling with hospital bills, so we appreciate very much Delegate Charkoudian's sponsorship and her commitment, and we thank the MHA and their hospital clients for leaning into this solution as well. I think we can all agree it's the right thing to do for these families. It's our pleasure, therefore, to request a favorable report on HB 333. Thank you.
Thank you for your testimony and for working with the delegate. She has been working on this all summer and fall, so thank you. Are there any questions for this witness? Seeing none, thank you for being with us. We have an unfavorable witness, Deborah Brocado. Are you here? I don't see her here, and this actually concludes the bill hearing on House Bill 333. Next, we have House Bill 482, Delegate Chetty. We actually are jointly assigned to Health and Government Operations Committee and Judiciary, and today we are joined by Delegates Tolles, Embry, and Arakan. If you have any questions when the bill is presented, please let me know so that I may call on you, okay? And welcome to our committee. Delegate, how are you?
I'm doing well, Madam Chair. Thank you so much. Good afternoon, friends on HGO, Chair Pena-Melnick, and my friends from Judiciary. It's wonderful to be before you this afternoon. For the record, I am Delegate Emily Shetty here today to ask for your favorable consideration of House Bill 482, a bill that seeks to enable access to personal, clinically relevant medical history to a donor-conceived individual. This bill came to me by way of a constituent, Jackie, who sits behind me today. She shared her story with me of discovering that she was donor-conceived much later in life after her parents had passed. She came upon this information after completing a DNA test out of her own curiosity. Eventually, she was able to identify her biological father, and she learned new family medical history as a result. She asked for me to introduce this legislation as a way to begin the dialogue of how donor-conceived individuals may better access their own relevant healthcare information. This bill has introduced models bipartisan legislation that recently passed in Colorado and would assist donor-conceived individuals in accessing their own medical history. This would enable them to reduce the risk of misdiagnoses, avoid unnecessary tests and procedures, and deliver more effective treatments. Upon introduction, we heard from a number of stakeholders, many of whom are either present today or who submitted written testimony about some of the challenges of implementing the Colorado model here in Maryland. We are working with all of them on a comprehensive set of amendments to address their very valid concerns, and I will be bringing those to the committee as soon as they are available. In closing, I urge you to support House Bill 482 with the sponsor amendment soon to come to help ensure that donor-conceived residents of Maryland have access to basic medical information that they need to lead healthy lives. Thank you, Madam Chair. And if I may, I'd like to go next to my witness here, Audrey, who will share her personal story.
Absolutely.
Thank you. Thank you so much. Good afternoon, Madam Chairwoman and members of the committee, and thank you for the opportunity to speak on behalf of HB 482. My name is Audrey Tornblum, and I was conceived by anonymous sperm donation in Washington, D.C. in 1985. My mother was told minimal information about the sperm donor, including his height, build, hair, and eye color. The attending nurse also shared he was completing his residency at a DC area hospital and had 2 daughters with his wife, one of whom had red hair. Growing up, I remember vividly scrutinizing the faces of every red-headed girl I met, wondering if she could be my sister. Around 4 years ago, I took 23andMe and Ancestry DNA tests, through which I learned the identity of my donor and connected with 3 half-siblings, all raised by my bio dad. My siblings and I lament that we were unable to grow up together. Not knowing my donor's identity had real implications and made my own health issues baffling. One of my recently found siblings shared that cancer runs on our paternal side, and one sibling and I share similar autoimmune issues. Genetic testing revealed that I am a carrier of cystic fibrosis, a potentially lethal condition which I inherited from my bio dad. I should have had the right to know family medical history which could affect me and my future children, and I shouldn't have had to wait decades and frankly get lucky to learn what was rightfully mine. Having an unknown number of half-siblings also made dating more complicated, as I could never be certain I wasn't dating an unknown half-brother. There was, and still is, no regulation requiring clinics to limit the number of people created by each donor, and some donor-conceived people have found hundreds of half-siblings. Lastly, learning the identity of my bio dad has been profoundly therapeutic, and my experience as a donor-conceived person has led me to the firm conclusion that those of us created by gamete donation have a right to updated and accurate medical history, and limiting the number of siblings is vital to prevent unintentional incest. It is for these reasons that I strongly support HB 482, and I hope I can count on yours as well. Thank you for your consideration.
Thank you for sharing your personal story with us. The
Thank you.
committee really appreciates it. We do have 3 favorable with the amendment on your panel, and they're virtually, so we're going to take a second to go to them, okay?
Thank you.
And then we'll go to questions. Good afternoon, how are you? Will you get started, Ms. Crozier?
Oh, of course. Thank you so much. My name is Patience Crozier. I'm the Director of Family Advocacy at GLBTQ Legal Advocates and Defenders. We work for justice for the LGBTQ community and people living with HIV, and my work specifically focuses on protecting children and families. I've worked in a number of states to ensure equal parentage protections for LGBTQ families and their children, and I've also worked on issues regarding gamete regulation in a number of states, which is particularly important to the LGBTQ community because so many in our community use gametes to build their families. I appreciate very much the work of Delegate Shetty to engage stakeholders on this bill. I think this bill touches on complex matters that need very careful thought to avoid unintended consequences of undermining LGBTQ families and limiting reproductive freedom. GLAD believes the approach of Article 9 of the Uniform Parentage Act of 2017 is the right approach and supports this bill with amendments to align with Article 9. Article 9 ensures that parents and people using donated gametes and adults born from donated gametes have access to non-identifying medical information and allows the child to have access to identity information at 18 if the donor agrees to be known. This legislation has been enacted in California, Connecticut, Rhode Island, and Washington, and we think that approach strikes the proper balance to ensure access to important medical information while at the same time avoiding unintended negative consequences. There are growing attacks on LGBTQ people and families across the United States, and a patchwork of protections for our families depending on what state you live on. And we think the focus should hopefully be legislating to shore up legal protections for families and to be very cautious about regulation of gametes and reproduction, and only with the engagement of all impacted stakeholders. Thank you so much. Thank you for Delegate Shetty for working with stakeholders, and I've also submitted written testimony.
Thank you. Thank you for being with us today. If you can hold on, when we're done, we're going to open it up for questions. Ms. Swain. If you can be so kind and unmute yourself. Thank you.
Yes, thank you. Good afternoon, Madam Chair, members of the committee, and Delegate Shetty. Thank you so much for your work on this bill and for your willingness to collaborate with those of us in the community. My name is Margaret Swain. I am an attorney in private practice here in Maryland, and I am also the president-elect of the Academy of Adoption and Assisted Reproduction Attorneys. We strongly support the core principles of House Bill 482, meaning facilitating the provision of medical information to donor-conceived persons, and where authorized, the release of donors' identification to the adult donor-conceived person. However, the bill as written would require every donor to agree to identity disclosure. Such a requirement, we believe, will impact the availability of donors, which in turn would thereby restrict access to care. Opting into donor disclosure without the option to later on opt out, as is outlined in Article 9 of the Uniform Parentage Act of 2017, is, in our view, a better option. This balances the donor-conceived person's ability to access information with the donor's privacy rights. We also see the bill's implementation, investigation, and enforcement provisions as burdensome tasks for the department and believe that they would carry a prohibitive fiscal note. All of these things taken together point towards a bill that does need refinement and a more carefully considered process and application. We, again, are very appreciative of Delegate Shetty's willingness to work with us on all of these issues and support a favorable report with amendments. Thank you so much.
Thank you very much for being with us. There's one more person, Lauren Pruitt. Is she on? No? Okay. So we're going to open it up for questions now. She's here? Okay. 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 Good afternoon, Ms. Pruitt. Will you be so kind and get started with your testimony?
Good afternoon. My name is Lauren Pruitt, and I'm the Legal Director for Free State Justice. We thank sponsor Delegate Shetty and the other family law advocates who are working on this bill to ensure it meets the stated goals, while also protecting the families formed via assisted reproduction. Free State Justice is very supportive of two key elements of the bill: giving individuals of any age who were born through assisted reproduction using unknown donor gametes access to non-identifying medical information of their gamete donor, and allowing donor-conceived persons over age 18 access to identifying information of their gamete donor if that donor consented at the time of donation. A significant number of families in the LGBTQIA+ community rely on assisted reproduction, utilizing eggs, sperm, and embryo donations. Even when successfully having children, many have issues becoming the legal parents of their own children. Although we support donor-conceived persons having access to important critical medical information, we want to ensure that the parent-child relationships in LGBTQIA+ families are protected under the law as well. In the amendments to this bill, we want to include necessary safeguards to ensure that assisted reproduction does not become more inaccessible or unaffordable, and that it is provided in a non-discriminatory and inclusive way. We have laid out in our written testimony provisions of this bill that are a cause for our concern. We would support a bill more closely modeled after Article 9 of the Uniform Parentage Act, which has been successfully enacted in several states. We think Article 9 more directly and narrowly meets the intended goals of this bill without the creation of regulation that would adversely affect families that rely on assisted reproduction and spur intense litigation over the various measures. Free State Justice has clients that are fighting for their parental rights against known donors, and this type of legislation without amendment could potentially cause additional issues when building their families, and even more importantly, when navigating custody issues. For these reasons, Free State Justice supports House Bill 482 with amendment. Thank you.
Thank you for your testimony today. We really appreciate it. We're going to open it up for questions now. So we have two committees, the HGO and the Judiciary Committee. We're going to start with the Judiciary members. Delegate Tolles.
Thank you, Madam Chair. Just a simple question. Hello, my friend.
Hello.
Delegate Shetty. I had a question on page 4 regarding the timeline. This seems to be something, obviously, sounds from your witness sharing her testimony that with, healthcare, cancer rates increasing and other healthcare concerns, that this bill will be necessary. Could you explain or just kind of let me know that's the reason for the timeline for January 1st, 2026, a little over 2 years in terms of when, this section would apply to that time period and why not before?
Thank you for the question, Delegate. The date selected is meant as a way to give those entities that would be regulated under this law, if passed, time to establish their systems to be able to collect the data if they have not already been doing so.
Okay.
Yes.
You have a clarification? You can have a follow-up.
Yes, thank you. And just they have different dates, I guess, each date. One has January 1st, 2026, so it's just different timelines for them to kind of get each entity to get sort of their information in order. On page 6, there's another date regarding collective gametes on or after January 1st. So they all about the same timelines, right?
Yes, I believe so.
Okay.
The three
I
dates
see.
that I see referenced are all January 1st, 2026.
Okay, thank you. That was my question. Thank you, Madam Chair.
Thank
My
you.
pleasure. We have Delegate Woods, followed by Delegate Kaiser.
Thank you, Madam Chair. And please tell me if the question is not relevant. I want to ask it to Ms. Swain. I see that you representation with adoption, and so I know that has been a big issue in areas where people are adopted and the records are sealed. And so there's been the big question for some time about medical history for those who have been adopted and have have records sealed. Has there been any further investigation in that, and has that kind of fallen into what you all are trying to do? And Delegate Shetty, thank you so much.
In response to your question, thank you for raising that interesting intersection of the two. In gamete donation, the person who provides the gamete is not a parent. So typically there is not a traditional type of adoption. So that would be a primary response. Secondly, adoption records.
Excuse me, Ms. Swain, will you be so kind and please put the volume up on your computer a little bit for us or get closer? Thank you.
I'm sorry. Adoption records are sealed as a matter of statute. In some states, there is a process by which you can obtain adoption records, particularly for medical needs. This is what we're talking about today with gamete donation is different in kind.
Do you have a follow-up, Delegate?
I just wanted to make sure I'm hearing her clearly. Thank you so much, Ms. Swain. So you're saying while they have the same similar interests because of the nature of adoption, there are stricter rules with sealed records as opposed to the gamete?
So adoption is a highly codified process in all 50 states, and there are laws that pertain to the availability of adoption records. The gamete donation process is different, and to my knowledge, what applies to the privacy of donor records has to do with medical confidentiality of records. So it is different. It's a different matter. Is that responsive to your question, Delegate?
Thank you. Next, we have Delegate Kaiser, followed by Delegate Bandari, then Delegate Hill.
Thank you, Madam Chair. Delegate Shetty, thank you for this bill. Certainly appreciate what you're trying to go for here. I would like at a later time to get from you the number of these gamete agencies, gamete banks, or fertility clinics that are in the state of Maryland. My question for you is in regards to these agencies, banks, clinics, and such, part of what they do when providing their product is that part of their business model is that if you pay a little bit, you get a little bit of information. Pay a little bit more, you get a little bit more. And if you pay a little bit more, you get a lot. How is your bill going to impact that business model?
Well, one, thank you, Delegate, for the question. And just quickly on your first question, the Department of Health letter of information notes that OHCQ licenses 14 fertility clinics and gamete banks within Maryland and 32 outside of the state that provide services to Marylanders. And then as for the question related to the business model, thank you for enlightening me on that. I did not know that that was part of the business model. Truthfully, I have some concerns about that. But as far as this legislation and with the sponsor amendments that we will be bringing, I think that it would enable access to all individuals to this, regardless of the payment information.
And may I make one comment?
No, we're not allowed.
Oh, I'm
Only
so
one
sorry.
person can answer, sorry.
Beg your pardon.
You're done?
So if you're feeding it back to me, I guess, Delegate Shetty, I'm just concerned.
I'm going to allow
how-
you one question. Go ahead.
Thank you. This
I'm generous today. Everyone has gotten one. Usually we stick to the one. Go ahead.
As you can imagine, this issue touches very close to home as I
know.
look at the amazing amount of information I have right here on my laptop about our donor. But I think this business model question, I think, has to be addressed of what people, again, of what the companies do and what someone is willing to share. So I guess that's just
What's
something
your
I think
question
needs to be
there?
worked on. I guess, thank you. Isn't that so?
All right, Delegate Bandari. Let's go with Delegate Bandari, followed by Delegate Hill.
Yeah, thank you, Madam Chair. Thank you, Delegate Shetty, for this wonderful bill. What is your response to the concern raised by the Maryland Department of Health in their letter regarding House Bill 482?
Thank you, Delegate Bandari, for the question. We are working with all stakeholders on a comprehensive set of amendments that will address all of their concerns. As for the elimination of anonymous gamete donation, they express that the industry has not reached consensus on the right of donor-conceived individuals for that information. I would respond specifically that there is basically no ability in today's society for a donor to remain fully anonymous. 23andMe, Ancestry.com, all of these services exist that are allowing for individuals to fairly easily identify their bio parents, as my sponsor panelist here shared in her story, as well as in my constituent's story earlier. As for the licensure question, I'm happy to work directly with them on this question and incorporate it as part of the sponsor amendment.
You want to follow up?
One of the things on the bill I like is by creating a separate licensure category, the state can better regulate these facilities and protect the health and well-being of patients. I like the part of that bill.
Okay.
Thank
you.
Okay. Delegate Hill, followed by Delegate Lewis.
Thank you, Madam Chair, and thank you, Delegate Shetty, and your witnesses, your panel. So it seems to me, particularly based on Delegate Kaiser's question, that there already exists the ability for donors to give information that would help them to be identified, and it's their option. I'm a little concerned that and again, your amendments may leave that option open, so I'm not clear. I'm a little concerned that by requiring that all donors give up anonymity, that you're actually encouraging people who want to donate to lie. So can you address that? I mean, I don't
Sure.
understand why it's all or nothing, why we can't.
Right. So the Uniform Parentage Act, which is the model that the sponsor of the favorable with amendment witnesses shared, is what we're looking to now, moving away from the existing bill as drafted, provides a better balance here of allowing for a donor to opt to provide their information at the time, like their identifying information at the time of donation, and then you know, there's just a better balance. So we're looking to addressing this issue as part of the sponsor amendments.
Thank you. Delegate Lewis.
Thank you, Madam Chair. My question's been answered.
Thank you. Delegate Kerr.
Madam Chair, since no one else asked it, I will. Does your half-sister have red hair?
One of them does. Yeah, one of them does. Yeah. And my younger brother did grow up in Northern Virginia, and he is very close to me in age, and we totally could have accidentally dated. Yeah, so it's pretty awkward.
Thank you. So Delegate, I noticed that the bill is not crossed.
It is not.
And the amendments are being worked on. So you have a lot of work to do in the next 3-4 days.
Yep, we have
Okay.
already corresponded with all of the stakeholders, received most of their feedback. We are just going through them now, and then we're going to be sending them to the amendments office. So we'll
Okay,
get them
make
shortly.
sure you share them with council and the committee, okay?
Yes, ma'am.
See no other questions or concerns? Thank you for your testimony.
Thank you.
We appreciate it. We have 3 more witnesses left. And those virtually, thank you for being with us. We have an in-person, 2 in-person that were not part of the panel. Audrey Turnblock and Sebastiana Gianchi. I hope I pronounced the last name. Okay. Okay, so how about Pam Casemeyer? She signed up favorable with amendment. You signed up favorable with amendment in person. Hi.
I know, I'm sorry.
It's
I came in
okay.
in the middle of the hearing, and I thought we were finished, and I missed my time. And
know, it's
I'm going
okay.
to give you your time back, because this is exceedingly complicated. It's Pam Casemeyer here on behalf of the American College of Obstetricians and Gynecologists, and mostly here to say I want to thank Delegate Shetty again, as everyone has, for working through this exceedingly complex issue. I have to be honest, when I read it, it made my eyes cross because I didn't even know what half the terms were. But we've worked through with a lot of other experts and things, and I think the amendments you're going to see are going to balance out some of the concerns and questions that were in the bill. And I know it'll be the subject of more conversation in subcommittee, but we'd like to support with the amendments that have been outlined previously.
Okay, thank you, and I think you're the last witness. So I appreciate it. Thank you for being with us and for working with the delegate. This concludes the bill hearing on House Bill 482. Thank you to our judiciary colleagues, Tolles and Breen-Aricam, for being with us today. You're welcome anytime. Thank you, Madam Chair. Take care. So we have next House Bill 596, Delegate Kurd, Health and Human Services Transportation Improvement Act of 2023. Will you be so kind and bring your panel if you have one? As soon as you sit down, will you get started? Thank you so much.
Thank you, and good afternoon again, Madam Chair. Delegate Ken Kerr here to present today House Bill 596, Health and Human Services Transportation Improvement Act of 2023. We talk a lot in here about access to care. Today we're going to talk about access to care. So access to health care is a daily challenge for rural residents. Residents living in any one of Maryland's rural communities must travel long distances to receive health care, routine or emergency. In addition, rural communities are also experiencing significant changes in the way health care is delivered in their communities. As rural communities continue to experience population decline and the delivery of health care is continually evolving, ensuring that access to health care will continue to be a challenge for rural communities. Studies have shown that there are fewer physicians in rural areas. A 2014 study, which was the most recent data I could find, found that there were 53.3 physicians per 100,000 residents in an urban area, but only 39.8 doctors in rural areas. It's also harder for rural residents to access specialized care compared to their urban counterparts. And a study from the University of Minnesota School of Public Health found that only 46% of rural hospitals had obstetrics care in-house, leading to declines in maternal health. Mental illness is as prevalent in rural areas as it is in urban areas, yet the availability of mental health is very different in these two communities. Mental health care needs are often not met simply because they are not present. The state of Maryland recognizes 18 of its 24 jurisdictions as rural. That means that 1 out of every 4 Marylanders live in rural Maryland. Rural Maryland communities face unique health challenges that not only include a lack of healthcare providers, but is compounded by the difficulty of access to those providers due to transportation and technology barriers. While pressing issues make it more difficult for rural residents to access routine care, this can lead to more significant and more costly emergency services. Rural populations are more likely to travel long distances to access health care, particularly subspecialist services. It can be a significant burden on rural residents as they travel far from their home communities, incur greater costs for care, and take time away from work and family. In addition, the lack of reliable transportation is a barrier to care. In urban areas, public transit is generally an option for patients to get to medical appointments, and public transportation is almost non-existent in rural areas. Rural communities are frequently home to more elderly residents with more chronic conditions requiring multiple visits for outpatient healthcare services. In addition, Uber and Lyft are simply just not available to rural residents. So House Bill 596 establishes the Rural Non-Emergency Medical Transportation Program within the Maryland Department of Health. Beginning in fiscal '25, the governor will be required to include an appropriation of at least $1 million in the annual budget. The bill also establishes a state coordinating committee for health and human services transportation in the Maryland Department of Transportation and repeals limits on funding for the Maryland Senior Rides Program and the Job Access and Reverse Commute Program administered by the Maryland Transit Administration. So as we work together to ensure that all Marylanders have access to quality, affordable health care, I urge a favorable vote on House Bill 596, which will put health care within reach of rural residents.
Thank you, Delegate, for your testimony. We have next Ms. Charlotte Davis, followed by Ms. Tricia Swanson.
So good afternoon, Madam Chair, members of the committee. My name is Charlotte Davis. I'm the Executive Director of the Rural Maryland Council. We're an independent state agency located in the Maryland Department of Agriculture, and we administer the Rural Maryland Prosperity Investment Fund. I want to thank our sponsor for putting this bill forward. It comes out of some work that we did this past fall. Part of our work with the RIMPIF Grant Committee is related to health care. That's a major challenge for our rural areas, and we fund a number of programs to get folks to to their appointments, to the pharmacy. We've tried a number of different strategies. We've tried volunteer models where volunteers pick up people. We've done community health workers where they pick up people. We've done the mobility management with the community action agencies, and they all struggle. They all struggle for funding, and they all struggle just for sustainability. So last year, we partnered with the Tri-County Council of Southern Maryland to host a series of roundtables. We hosted them across the state, one in Cumberland, one in Cambridge, and one here in Annapolis. We brought together transportation folks, transit folks, and the healthcare people to really just boil down what seems to be the challenge. The big thing is there's no coordination between the different industries. The healthcare folks do not talk to the transportation folks. We want more transportation coordination amongst the different industries. We had a coordinating committee. It hasn't met since 2016. We'd like to bring that back so that we can have a venue for that discussion to occur. We know we need additional resources. That's why we asked for the caps to come off. And then we need a new model for rural transportation. We think we've got something with the Wheels to Wellness program, but it still needs additional resources and support. So I know Delegate Lewis participated in those roundtables. We thank you for that participation, and we ask for your favorable support of House Bill 596. Thank you.
My pleasure. Delegate, can you tell me the person to your right? Could you give us your name, please?
My name is Yolanda Hipsky.
Okay, you're not signed up, and I'm not able to take your testimony. And I apologize for that, but I do have Tricia Swanson. Thank you.
Good afternoon, Madam Chair, members of the committee. My name is Tricia Swanson, and I am the Acting Director of Government Affairs for Care First Blue Cross Blue Shield, here in support of House Bill 596. Care First has taken a particular interest this session in supporting transportation and transit bills, both as a large employer in the state and also as a carrier focused on social determinants of health. A few weeks ago, we were just across the hall testifying on a bill that would support our transit-oriented development projects. So we wanted to make sure we were here today to support Delegate Kerr's bill that would encourage more investment and coordination for transportation in our rural jurisdictions. As many of you know, and you've heard us say, we have members in every jurisdiction in Maryland, and so with that perspective, we have visibility into how regional barriers to transportation lead to missed or delayed doctor's appointments, fewer prescription refills, and overall poor health outcomes. All of these contribute to an increased economic burden on the healthcare system and overall community health, directly affecting people's access to much-needed healthcare services. So while we're not in the transportation business as a healthcare company, we're proud to join in support of this bill to call for investments and a greater analysis as to how best to connect people to the care that they need. Thank you for the opportunity to testify, and we would respectfully urge a favorable report.
Thank you for your testimony today. Are there any questions for the sponsor of this bill and his panel? I'm going to start first with Delegate Lewis, followed by Delegate White.
Thank you, Madam Chair. Thank you, Delegate Kerr, for this bill. It's so important. To Ms. Davis, thanks for all of your work as well. I realized that you said something important, which was that health folks don't talk to transportation folks, and I hope this bill will help address that gap. My question is this. When I attended the roundtables, I heard a lot of stories about individuals, folks living in rural areas who've missed dialysis appointments and worse due to lack of transportation. I'm curious though, will this bill also help address transportation for health workers, frontline folks based in rural areas? That may be an aspect of the health care gap. So I'd love to hear your thoughts on that, whoever's best to answer.
There is the job access and reverse commute piece to the bill, which would help address, workers getting to jobs and employment. It lifts the cap. Currently, it's capped at $500,000, and it would lift that cap so that, yes, that potentially there would be the, available funding to help support job access for healthcare workers.
Thank you, Madam Chair.
My pleasure. Delegate White.
The question that I have relates to the nonprofits in the mix here and all of the counties that would be considered rural. And it really relates to, one, have these nonprofits been identified, and really do they have the capacity to take this on? I assume that this would go through a competitive RFP process for them to be identified, but in the locations that are listed in the bill, is the nonprofit community in a place to offer these types of services? So could you share a little bit more about how the nonprofit community would actively play a role here, and do they have the capacity?
What we see is a number of small volunteer-run programs across the state, so they are ready and willing. They're seeking resources. The community action agencies are definitely, organizations that are currently out there providing these services, but they tell us, and we fund them too, that they struggle for resources. They just grab funds wherever they can and cobble them together, and it's a struggle for all of them. And then the regional councils, we do have three actually. The Tri-County Council of Southern Maryland, who's here, unfortunately wasn't able to give their testimony, and then the Tri-County Council of the Lower Eastern Shore also offer these transportation services. So this would be, they're there, they're ready, they just need more resources.
Thank you. Delegate Hill.
Thank you, Madam Chair, and Delegate Kern and panelists. So what I'm curious about, this is important, curious about how the information get out to the residents so they know about the program. And in doing that, how do you ensure equity? Because communities differ in terms of generally in terms of their access. So how do we make sure that all the residents who might qualify and may be differ by racial, ethnic, religious, other groups are going to have equal access to this program?
So part of our work with the roundtables is we did a pre-survey of all our participants to ask them, where do you go currently? Do you know where to go to get these services? And the response, we received 325 responses, and the answer overwhelmingly is, we have no idea. So we believe, it's not covered in this bill, that it should be braided with 211. As folks are calling up for resources for housing, for food, that this be included in that discussion so that so they know where to go. That is a big challenge. Folks do not know where to go to get these services. So we're hoping that's an outcome.
Sure.
Given that that's the case, I think that partnering with 211 is a good thing, right? It's a start. I'm wondering if you have other ideas, because some of the people we're talking about have no idea that there's a 211. So partnering with something they don't know about kind of leaves us back where we started.
Yeah. So I think that's something that we need to work on, is to get that out, because we do hear that a lot.
Thank you. Any other questions? Seeing none, thank you so much for being with us today. We really appreciate it. We have an unfavorable by Deborah Brocado. Not here? Okay. So we have 3 virtual testimony. We have first Nora Miller Smith. Actually, if you could bring all of them up. Courtney Thomas Winterberg and Erin Farley. They're all favorable, and they're all virtual. Ms. Miller, will you be so kind, Miller Smith, and get started, and welcome?
Thank you. Thank you. Good afternoon, Madam Chair and members of the committee. My name is Nora Miller Smith. I'm speaking on behalf of the League of Women Voters Maryland in support of House Bill 596, and I'm also speaking as a nurse. The League believes that healthcare is a human right. All Maryland residents need access to affordable, equitable, quality healthcare. And this bill links access to healthcare with a very important social determinant of health, transportation. Lack of access to reliable, affordable transportation disproportionately affects the elderly, the disabled, low-income Marylanders, and rural residents who often must travel long distances to reach healthcare services and providers. Transportation is independence. Every young person with a new driver's license knows that. Every patient knows that also. As a patient, you have to get your medicines. That means you have to get to the drugstore. If you don't get your meds, you may wind up in the emergency room. You also need to get to the doctor, and telehealth is wonderful, and it works so well for some behavioral health care, but you have to have a smartphone or a computer, good broadband access. You have to be able to hear well, see well, and sometimes you actually just need to get to the doctor because you need hands-on care. Also, if you're being discharged from the hospital with a serious condition, like a new diagnosis of cancer, you have to be able to get to your radiation therapy appointments. That's 5 days a week, maybe for 6 weeks. You can't miss it or the treatment won't work. That puts your life at risk. As Delegate Lewis was saying, sometimes people with new dialysis, they have to get to dialysis. It's 3 times a week. You can't miss it. Or again, you'll wind up in the ER or the ICU. So dependable transportation is so important to patients. This bill will make it easier for rural residents to get the essential health care they need, and it will remove a huge worry for so many patients and their families. We urge a favorable report, and thank you so much for allowing me to speak.
Thank you for being with us. May I have Ms. Erin Farley, will you please unmute yourself and give us your testimony?
Hello, I'm
Hi.
Erin Farley. I'm a registered nurse, the mother of 6 children, and blessed to be the daughter of 2 parents over 80. We have no other family members in Calvert County where we live. We found ourselves in a situation where my father needed multiple visits each week during an acute illness. My father and mother are intertwined for their very survival of 56 years of marriage. They are dependent physically and emotionally on each other. After 27 years as a government employee, my dad is sharp as a tack, but he doesn't move very well, and my mother has dementia, but she can move very easily. They're very proud people. They would not ask for help. And I think one of the things that we have not touched on today is the fact that many seniors in this situation, they're not going to tell anyone that they don't have a ride each day to go to these multiple doctor's appointments. They're not going to share this with their doctor. They're going to self-select what they feel is important doctor visits to attend each week. Therefore, they could be self-selecting the wrong visits each week, right? So we use the Wheels to Wellness program here in Calvert County. It was a godsend. The other thing we need to consider is when we're talking about transportation is why doesn't public transportation work? Well, because they can't accommodate wheelchair and walkers and people who are on medication and may need to use a restroom, when in my county it's 50 miles from one end to the other. Once you get on public transportation, you have to ride that whole loop to get back to where you started at. So just kind of thinking about outside of the box, the more human aspect of this is that we don't have Uber, we don't have Lyft. When you are a middle income, my father was a government employee, he has Blue Cross and Blue Shield, but there's no coverage for transportation during these acute illnesses.
You can finish your thought, it's okay. You're done?
No, I'm good, thank you so much.
Okay, thank you for being with us. We have next Ms. Thomas Winterberg. Good afternoon, will you be so kind and unmute yourself? You can get started.
Good afternoon, Madam Chair, members of the committee. I am Courtney Thomas Winterberg. I am the chair of the Transportation Committee for the Allegheny County Chamber of Commerce. Thank you for the opportunity to support House Bill 596. We know that transportation is essential for accessing medical care, especially for people who face mobility, financial, or geographic barriers to health care. The importance of transportation to medical appointments cannot be overstated, as it ensures their patients have timely access to the most appropriate medical care, which is crucial for managing and treating health conditions. Since 2012, UPMC Western Maryland, located here in Cumberland, has worked to improve access to care by helping to coordinate rides to health and human service appointments for underserved residents through our community partners. Between January of 2020 and April of 2021, the hospital helped provide 14,466 total rides. 27% of these required wheelchair assistance, and 47% were for dialysis. We know without the provision of these rides that many of these individuals would not have access to the care. In Allegheny County, our hospital and their partnerships with our nonprofit partners have been key to providing underserved residents with rides to needed health appointments when no other resources exist here in our community. House Bill 596 establishes a rural non-emergency medical transportation program with an annual appropriation to support hospitals like UPMC Western Maryland, working with our nonprofit providers to address transportation gaps in rural communities, making sure that everyone has needed access to medical care. It also improves the coordination by establishing a state coordinating committee for health and human service transportation to develop a cooperative and coordinated approach to transportation in rural communities. For these reasons, I respectfully request a favorable report for House Bill 596.
Thank you. Thank you for being with us. Are there any questions for these three witnesses? Delegate Lewis.
Madam Chair, I'm curious, and thank you to the witnesses for their testimony. I'm curious if any of you can answer this question. Is there any connection between investment in rural health transportation and the impact on healthcare costs? Our all-payer system, our total cost of care sets a cap on how much hospitals can spend. Is it possible that investing in rural health transportation could help us get a grip on costs? Anyone who's best positioned to answer? Maybe the Chamber of Commerce.
So if I may try to answer that to the best of my ability. I worked at the Community Action Agency that initially helped stand this program up with UPMC Western Maryland previously. And it was about making sure that people could access the care they needed when they needed it versus relying on emergency medical services to transport people to the emergency room to receive care because there was no other opportunity to be able to access needed care. So yes, I do think there is an opportunity by providing needed transportation supports to make sure that people are being treated in the most appropriate setting at the earliest intervention point.
My pleasure. Delegate Taveras.
Thank you. Just wondering, is there any what we tend to call like villages or like programs that we call typically like aging in place, where I come from, and these are targeted to assist seniors and individuals that are disabled to be able to attend their appointments. In addition to, we tend to use villages as well as taxis, that are specialized just for this. Are any of the counties in question already engaging in this kind of activity, and it has not been working?
Who are you directing your question to?
Anyone who can answer from the virtual panel or?
The virtual panel is the only panel available. Is there someone on the virtual panel that can address the delegate's question? If not, she can contact the sponsor. Any of you are able to answer it? Seeing none. If you could be so kind and contact the sponsor, okay?
No problem.
My pleasure. Any other questions? Seeing none, thank you so much for being with us today and for making the time. And this actually concludes the bill hearing on House Bill 596. Next, we have, and I want to thank the people that are waiting for the last two bills, House Bill 1148 and 626. Thank you for your patience. As you can see, we have been moving it along and are very grateful for your time and your efforts. Next, I would like to call House Bill 1148, Delegate Moon and Delegate Healy. I know that we have a rule where other delegates do not testify on other delegates' bills. However, they've been working on this since the summer and the fall. So Delegate Healy and Delegate Moon, so they are going to be providing the testimony. And can you be so kind, if I may, I need Lori Doyle, Nicole Gratner, Dan Martin, Daniel Reck. If I may have those people first, that will be the first panel because we have several panels. So again, Lori Doyle, Nicole Granner, Dan Martin, and Daniel Reck. If you can come up. Delegate Moon, you can get started, and good afternoon.
Thank you, Madam Chair. Thanks, colleagues. I'm not usually in the HGO committee, so I am here today with House Bill 1148. This is a bipartisan bill, and simply put, this is really an effort to insist that Maryland finally rebuild and adequately fund our state's behavioral health system. We got to stop sweeping this under the rug. I wish I were here under better circumstances, but frankly, I'm a little bit fed up, and I'm now swerving way out of my judiciary lane here into HGO, but it's because this is my 9th year on the Judiciary Committee, and we tinker with sentences and criminal reforms and what the appropriate penalties should be for various behavioral health issues that end up when we don't do anything in the judiciary basket. And I think I've squeezed about as much as value as I can out of these penalty changes, and at some point, we've got to turn to the hard work of rebuilding the health system. When I asked about this the first year I got down here, heard about rural police chiefs talking about having to jail people for loitering because they were being discharged from hospitals. And I asked about this, and I said, well, Moon, you're asking some very expensive questions. I don't know if that's true, given that these folks end up with $30,000 prison stays and emergency room visits instead, but that's why I'm here. So I want to be very thankful for the chair and Aaron Hopwood, Delegate Bagnall, Delegate Resnick, Bonnie Collison, and the other members who have graciously lent, because this is not my area of expertise, but you've lent your expertise and time to this effort of trying to put pen to paper basically on a 4-year commission and study that's going to be a deep audit and dive of how we do this, inpatient, outpatient, workforce development, reimbursements, funding sources, and the like. I've seen this in a couple other areas when we did justice reinvestment and the school blueprint, and I'm hopeful that this will be the thing that takes the same serious eye and turns it towards what we all know is impacting Maryland families. So I don't want to bore you with too many details. There's obviously, we had to pick a 32-member assembly for how to take this unwieldy topic and try to make some sense of it. There are going to be a number of folks who are favorable with amendment, and I think the amendment is going to be to add themselves into this discussion. So I just want to make you aware of that. But I just want to give you a couple items, and I'll shut up just so that you understand why I'm here. Every year we have a bill that asks us in judiciary to reform the use of segregated confinement or solitary in our corrections system. And every year it's opposed. But the testimony is always very, very illuminating. Last week we had basically every single warden and corrections officer from around the state, from all your counties in our committee, opposing this bill to lighten up on the use of solitary confinement. And the ACLU was showing us PIA documents with people in 8,000-day stays in solitary. And you look at that, and I said, this has got to be some sort of behavioral health challenge that person is exhibiting. So here's just a sampling of the testimony from our prisons officials opposing changing solitary confinement. St. Mary's County, jails have become de facto mental institutions. Individuals cannot be forced medication in jails because they don't have the resources of the state mental hospitals, nor are they authorized by law. Other official, we have people committed who are supposed to be transferred to the hospital staying for 50 days. They're all under restricted housing while they're here. Another one, largest segment is suicide watch. They are all under restrictive housing. Another one, I've got 100 or 200 people just from the detention centers, and another 200 that the Department of Health is trying to move out of the hospital so they can open up bed space. This problem has been going on for 15 years. Allegheny County, I have 188 inmates. 97 of the inmates are on psychotherapeutic medication. And I could go on and on and on, and these are the people that end up in the jails. And this effort is obviously trying to get to people before they get to that point. So that's what this is about. We all know we need to do this. Let's take the deep dive and spend this term doing it and deliver some results for our people. Thank you.
Thank you. Next, please.
Thank you, Madam Chair, members of the committee. First, I'm Delegate Ann Healy. I'm also out of my element. I've never testified on another member's bill, but this is personal for me, and I'd like to talk a little bit about this. House Bill 1148, I want to thank the sponsor and the chair for allowing me to be part of this. Over my 32 years as a delegate, I have over several times had to and been able to intervene to help desperate parents of adult children in crisis to get the help they need. It should not take the intervention of a legislator for people to get the help they really need. Maryland is a wealthy state, but when it comes to caring for people with mental illness, we have fallen very short. And as I said, this is personal for me. My younger sister, 10 years younger than me, right now lives in a state mental hospital in Pennsylvania and has for about the last 10 years. She has been in and out of mental hospitals and behavioral health institutions since she was a teenager. She has been homeless in Philadelphia and New York City, but right now she is in a community where she is truly known by the mental health professionals, the police, the courts, and she gets the help she needs. It's not perfect, but her basic needs are met. She gets her meds and is sheltered and fed and has her physical health cared for. When she had a stroke, she was flown to specialized treatment in Hershey. When she had breast cancer, she got the treatment she needed. She would not have survived if not for Clark Summit State Hospital in northeastern Pennsylvania. The number of beds available in Maryland for people like my sister has almost completely vanished. Institutions closed without community-based services to replace them, and without the recognition that there is a certain portion of the population who will need institutional care, sometimes for years. After decades of failed policies that have left us with no safety net, this bill will provide us with a way to learn from the best practices in other states and do that deep dive to help us to create a blueprint for designing a system of behavioral and mental health care that will leave no one behind. And I'd be happy to answer any questions. I tried to keep this under 2 minutes.
Thank you. Ms. Doyle.
Thank you, Madam Chair. Lori Doyle here on behalf of the Community Behavioral Health Association of Maryland in strong support of this bill. I too want to thank Delegate Moon and you, Madam Chair, for your leadership on this bill. It is a package of bills of behavioral health initiatives that is probably the most important thing you'll hear this session in terms of behavioral health. You all hear the steady stream of problems and concerns around behavioral health and access. Well, I'm here today to offer you a couple solutions that are in this bill. The first is Certified Community Behavioral Health Clinics, CCBHCs. They have been adopted as a model now in 26 states, including in our neck of the woods, New York, New Jersey, Rhode Island, Pennsylvania, and West Virginia. They have a proven track record of addressing the very problems you all hear day in and day out: overutilization of emergency departments and inpatient units, the dearth of children's services, the need for increased access to opioid and substance use disorder treatment, workforce challenges. So if you look at our written testimony, there's tons of data on there. We appreciate you taking a look at it, but I only have 2 minutes, so I can't go into it. The second component that's important in this bill is value-based purchasing. It's a pilot program. We know that financial incentives drive behavior. Right now, under fee-for-service, providers are incentivized to provide more services, not necessarily better ones. Value-based purchasing is not a new concept. It's used in Medicare, and it's our TCOC, our total cost of care model, is a value-based purchasing model. This bill creates a 3-year pilot program targeting 500 individuals who tend to overuse EDs and inpatient care. And the whole notion is that money is withheld until we meet the outcomes that the state has determined, including ED utilization reduction and total cost of care reduction. These things are going to address the stuff that you hear constantly. So we appreciate you taking a close look at this bill, and thank you for your support.
We're going to go on to the next two witnesses and then open it up to questions. But before we do that, I do want to take a minute just to say thank you. When I called the delegate last summer about leading this bill and we brought everyone together, it was a concept. He held a lot of meetings, and Aaron, I want to thank you because Aaron really worked really hard on this bill. And it is, I would say, one of the most important bills we're going to pass, God willing, this session. So thank you for your partnership. It would not have happened without your leadership. And thank you, Delegate Haley, for sharing your personal story. We do have next Ms. Nicole Grainer, and then Dan Martin. Are you here?
I think he's stuck in Senate Finance,
All right,
Madam Chair.
Yes.
Good afternoon, Madam Chair, members of the committee. My name is Nicole Grainer, and I am the Manager of Communication, Marketing, and Advocacy with Cornerstone Montgomery. We're the largest behavioral health provider in Montgomery County, Maryland, and at the end of April, we will be expanding into Calvert, Charles, and St. Mary's counties. We have been a CCBHC since 2018, and as a result have seen amazing outcomes for our clients around access to services and reduction in hospitalizations. I've included those in my written statement, and today I want to focus on our services to our non-native English-speaking patients. Montgomery County is a diverse county with over 40 languages spoken. We are committed to serving all members of our community, and in 2019, implemented on-demand video translation services. As a result, we've been able to better assess, treat, and refer our non-native English-speaking clients. I want to share just a few examples with you all. Our supported employment team has used translation services to support a client with interview preparation, benefits counseling, and meeting with their DOORS counselor so that they can maintain their employment. Our crisis program has helped an individual who came to us out of a state hospital get a COVID-19 vaccination, begin long-acting injections to support their medication compliance and stay out of the hospital, apply for Medicaid, and connect with our assertive community treatment, and later our residential rehabilitation program for stable housing. A child and adolescent psychiatrist uses the translation services to meet with and treat a deaf patient. Finding a live ASL interpreter has been a barrier to treatment for this individual, and we are now able to provide psychiatric services that would otherwise be impossible. We have served clients who speak 23 different languages, including American Sign Language, Amharic, Russian, Arabic, and Cantonese. Being a CCBHC has benefited not only Cornerstone Montgomery, but Montgomery County as a community. The CCBHC model is the future of behavioral health, and it's time for Maryland to invest in the lives of its most vulnerable and commit to implementing and fully funding CCBHCs. We respectfully urge a favorable report on House Bill 1148.
Thank you for your testimony. We really appreciate it.
Thank you.
So this actually is the first panel, and we're going to open it up for questions. Are there any questions for the delegate and his panel? We have Delegate Hill.
Thank you, Madam Chair. Delegate Moon, thank you so much for this. I'm looking at some of the tasks that that would be put to this committee or commission, and one of them has to do with looking at the workforce. And what I see missing here, and I've been in conversations with employees at our state institutions on both the nursing and the correction side, and I don't see them represented. And they're at the front lines, and they're the ones who are dealing with these patients. And I just want to know, in addition to the other suggested amendments, do you have any objection to making sure frontline workers are represented in this discussion?
Certainly not, though I will tell you, I'm going to have to put it somewhat on this committee to create a manageable process for looking at amendments to the commission membership. There's that one, folks from the family wing, representing families of IDD children wanted in on the commission, and there's actually all of these have very good, sound reasons. Last year, I tried a version of this bill that was very much heavily focused just on the justice-involved populations, and I think the commission membership list we came up just on that was, over 14 people. So I don't quite know how we'll manage the process, but I think the first cut was trying to do a very direct stakeholder top level view, but I think there certainly will be room for discussion about whether we should include more folks.
And if I may, we just dealt with a similar bill also that we started working on last summer is the Public Health Commission that this committee passed, where we had work groups, and that this bill will be assigned to the Public Health Subcommittee, which will deal with that as well. And I know that there's a question from our new Public Health Chairman, Delegate Bagnell.
Thank you, Madam Chair, and thank you, Delegate, for your work on this bill. My question is actually for Ms. Doyle, because looking at the fiscal note, there's sort of two stories with the CCBHCs. There's the per person cost, there's the overall cost. So if you could just speak a little bit to the experience in other states of the CCBHCs, so the committee can have a better understanding of what this looks like.
Thank you, Delegate Bagnell, for the question. We have been working with our national experts who help implement CCBHCs in numerous other states, and they've looked at our fiscal note and have said that it seems out of line. There might be some misunderstanding on the part of Medicaid, that it's about 4 to 10 times what they see in other states in terms of the amount of money needed, and 4 times the number of PINs needed. They think that maybe they're perhaps not understanding that the state is in the driver's seat. The state can determine how many CCBHCs, how quickly they roll them out. They authorize the budgets for the CCBHCs. And of course, fiscal notes never take into account the cost offset. And what we know from New York State, that's had one for some time now, there was an evaluation by an outside entity that found that they were budget neutral within 3 years. So we'd be happy to bring in any of those national experts to talk with you if that would help, but we think that there's maybe some misunderstanding of the model.
My pleasure. We have Delegate Lopez, followed by Bandari.
Thank you, Madam Chair. And this, my question or comment rather, goes in line with the composition of work groups and that conversation. I'm noticing that there's 4 work groups that are outlined in this bill, and I was just wondering if you would be open to consideration of another work group. There's geriatric, youth behavioral, criminal justice involved, and workforce development. Would you be open to considering gender or women's mental health or behavioral health also as a part of this?
Certainly, and I think 2 ways of answering that. First, you'll have to, again, the committee will have to noodle through which of this code-designated work groups, subgroups it wants to create, and then I presume the chair and commission would be able to have not code-designated discussions of subgroups too that are sort of outside the 3 annual required meetings.
Thank you. We have Delegate Bandari.
Thank you, Madam Chair. Thank you, delegates, for this wonderful bill. MDH supports the implementation of this Certified Community Behavioral Health Center, but proposes amendment to require that MDH apply for a certain federal grant for fiscal year 2025 to fund the implementation of the center rather than using state general funds. Do you want to have a comment on that?
I'll kick that over to Lori, since she's deep in the CCBHC funding world.
Thank you, Delegate. We did read the department's letter. So what we're suggesting to the department is eventually they're going to have to go for a state plan amendment. That's part of the CCBHC model. Go for the state plan amendment, then go for the planning grant that's available in 2025, and then the demonstration grant that you're referring to in 2026. And the reason those dates are important is we now have 5 grant-funded CCBHCs in our state, in Montgomery County, Anne Arundel County, Baltimore City, Baltimore County, and they are up for grabs if the federal grant is not extended. So it's very important that we get this rolling before that happens, because there's been a lot of work and a lot of foundation built for this model, and we'd hate to lose that momentum.
Any other questions? Delegate Lewis.
Thank you, Madam Chair. Delegate Moon, you are always welcome in HGO if you're going to bring good work like this. My question is as follows. I might have missed it, but I don't think I saw the State Department of Housing. And if that's the case, I hope the sponsor would be willing, and if I'm wrong, I'll eat crow, but if not, I hope the sponsor will be willing to consider housing. My understanding is that housing is actually a treatment for mental illness. And finally, if I may, Madam Chair, follow-on question. Sure. This effort reminds me so much of what the legislature tried to do for public education, and the nickname or tag name for the effort was the Kerwin Commission. And I'm just wondering if the sponsor would be open to having this effort named the Moon Commission, and if so, I hope
that's a little weird.
Is that weird?
Yeah.
Thank you, Madam
the
Chair.
The JPM Commission sounds more
Thank you
to
so
my
much.
liking. Yeah.
Thank you. We have any other questions? Seeing none, thank you very much. Thank you, Delegate Moon, for all your efforts. We have Dan Martin who walked in. We're going to allow it. Go ahead.
I appreciate it, Madam Chair.
Just remember that when we call you.
I remember it. I ran over from finance to be here, so
Okay.
thank you for the opportunity. Dan Martin with the Mental Health Association of Maryland. Just real quickly, in support of this bill, we support all pieces of this bill. I'll just talked about two of them real quickly. The CCBHC piece, which you've, I think, heard of already. We have never been in more dire need of the types of services that CCBHCs provide than right now. Hospitals in our state are seeing tens of thousands of Marylanders a year for suicide attempts. They saw a 35% increase in total suicide attempt ED visits from 2020 to 2021, including a 46% increase among children and youth and a 40% increase in those over 65. New CDC data out just last week show that 60% of teen girls reported feelings of persistent sadness or hopelessness, and a full 30%, or 1 in 3, said they've seriously considered attempting suicide. And so CCBHCs can help. Outcomes from the states operating these programs around the country and from those operating in Maryland, which I think you'll hear from soon if you haven't already, are beyond impressive. The establishment of a state-run CCBHC program pursuant to this bill is critical to maintain the momentum of these programs, build on their success, and provide Marylanders with the community resources they so desperately need. And the other piece that I'll just talk about real quickly is the Behavioral Health Commission. Stakeholders in the state have worked long and hard to address an increasing demand for mental health and substance use care across the state, and after many years, we are finally starting to see attention to and progress across key pillars of the behavioral health care continuum. The CCBHC piece of this bill and other bills being considered this session will increase community-based services and supports, crisis response services, and more. And as reforms in these areas progress, this commission can play a really key role in ensuring that these efforts are integrated, coordinated, and properly resourced. And as such, we'd urge the commission to develop a plan quickly that guides state coordination and support for these ongoing reform efforts, and then really focus on oversight and execution of the plan, including allocation of resources necessary to ensure the plan's success. And so, for that reason, we support all pieces of this bill and thank the sponsor for introducing it, and happy to take any questions.
Are there any questions? Seeing none, thank you very much.
Thank you.
May I have, please, the following people, if you can come up. Daniel Reck, Demetrius Cavatas, Cheryl Neverson, Keisha Monroe, can you get started, please? Will you be so kind and get started?
Sure. Good afternoon, Madam Chair and committee members. My name is Dan Reck. I'm the CEO of Mac Clinics, testifying in support of HB 1148. Mac Clinics was established in 2016 to provide high-quality outpatient addiction treatment. We have 8 locations across Maryland and treat more than 4,000 patients annually for substance use disorders. 75% of our patients are Maryland Medicaid beneficiaries. I spent most of my career in financial markets until a family member's experience gave me a front row perspective on the need to improve the quality of care and addiction treatment. My co-founders and I launched Mac Clinics with the goal of doing just that by applying our experience in successfully managing large, sophisticated businesses. At the expense of profitability, we have funded the development of systems that demonstrably improve outcomes for our patients. One of these systems is the use of data analytics to help patients achieve recovery more efficiently, an approach we developed with scientists at the National Institute of Drug Abuse, that is documented in the peer-reviewed Journal of Addiction Medicine. Essentially, we calculate scores which represent adherence to treatment. Low-scoring patients are allocated more intensive resources, such as intensive outpatient counseling, while high-scoring patients are able to engage in maintenance treatment only. Unfortunately, in a fee-for-service environment, our investments in such systems are not reimbursed. Without an incentive to improve patient outcomes, why would any other provider offer additional unreimbursed services? And why would we continue to do so? I strongly advocate for the passage of HB 1148 to allow Medicaid to pilot a program in which quantifiable performance standards are used to reimburse providers. Mac Clinics has demonstrated that data can be used on a patient-by-patient, visit-by-visit basis to improve health outcomes. Thank you for the opportunity to share my perspective with you today.
Thank you for being with us. And your timing was perfect. Can you follow that, please? Can you go?
Thank you, Madam Chair. I appreciate that. My name is Dimitri Kavathis. I'm the CEO of the Lower Shore Clinic. Serve 2,000 people in the lower part of the Eastern Shore. 700 of them have a serious and persistent mental illness. We have been recently designated as a certified community behavioral health clinic. But the problem is the federal government designated us, but we don't have a value-based payment for this. And we need the state of Maryland to really support this. And what do I mean by value-based payment? A payment bundle that pays us for outcomes and allows us to have flexibility in what we do. And if you think about the kind of things that can really impact people's health, some of those payments don't support that. What do I mean by that? I mean, if I have someone with depression, anxiety, diabetes, and high blood pressure, I'm only allowed to provide certain kinds of services for that. However, if I'm allowed to have a bundled payment that allows me to do other kinds of things to support a person to reduce their issues around their health, then I can do an amazing amount of good, not only for the person and the citizen of Maryland, but also for the cost of care. And we can therefore bend the cost curve for healthcare. So why not help me pay for example, transporting clients to their appointments, help them shop for healthy foods, help them decide the kind of things they should do around activities for walking. All these kind of things will reduce not only the cost of care, but also improve their lives and make them much happier, and also improve the cost of care over a period of time. So allow us to, as providers, to have the flexibility in a value-based payment to really make a big change for our system. Thank you so much.
Thank you for being with us and for traveling here to testify, all of you. Next, please.
Good afternoon. My name is Dr. Cheryl Neverson, and I am currently the Senior Vice President for Clinical Strategy at Volunteers of America, Chesapeake and the Carolinas, where we provide housing, reentry services, mental health, addictions treatment for over 3,000 Marylanders every year. I myself am a native Marylander of Prince George's County, Maryland, and in April of 2020, our agency was one of those that was selected to establish the CCBHC right in the midst of the pandemic. And we did. We did so successfully. We increased our workforce by 30 new hires. We increased services, integrated services, both mental health and primary care services, to over 810 children and adults. And we demonstrated positive health outcomes across key metrics. We also increased Medicaid and Medicare enrollment by 362 clients. Unfortunately, we were one of those applicants that did not get refunded in this last cycle, leaving us at risk of not being able to continue the amazing work that we started. One aspect of this model is that it allows us to treat anyone regardless of their ability to pay. And ironically, last week, I got a call from a community crisis center stating that they had a 17-year-old female who was undocumented and uninsured and who needed substance use help and therapy. And they heard about our model and wanted to know if we would be able to help. And at this time, I'm like, sure, we can help you. But if we do not get the support, we will not be able to continue this work. We won't be able to continue this work with the underserved populations that look like me. And so I urge you to support this bill in order to continue this great work that we've been doing. Thank you.
Thank you for being with us. We have Ms. Keisha Monroe. You can stay there. She'll come back for questions. Go ahead. You can get started.
Good afternoon, Madam Chair, members of the committee. My name is Keisha Monroe, and although I serve as Chief of Staff for Chair Healy, I am here as a sister and an advocate for people with severe mental illness. And thank you for the opportunity to speak today. I can't speak to the statistics, but only to my story, and I want to tell you a little bit about my brother, who has paranoid schizophrenia. My brother is a gentle, intelligent soul who got sick when I was 10 years old and who had a full psychotic break when I was 12 years old. Ironically, he had just finished up his internship as a 4.0 student at Towson State and had just finished his internship at Shepherd Pratt Hospital because he wanted to be a psychiatrist. He lost his ability to speak for 2 weeks and was taken to Springfield Hospital for 3 months where he was medicated, period, just medicated. And my mother swore that she would never see him institutionalized again. And as the years passed, that included group homes and assisted living facilities. That was in the winter of 1980. He's been home ever since. It's been 43 years. I moved home several years ago to care for my mother until her death in 2017, leaving me to care for my brother, who is now 63, as well as my 57-year-old brother, who has developmental and communication processing disabilities. There's a lot of language in the bill about identifying needs and gaps and helping the individual to navigate the healthcare system effectively and efficiently. There are current COMAR regulations that require specific actions which are currently not being met in my brother's care. So while it is necessary to identify gaps in services, it is also necessary to begin increasing the staffing and probably the pay at the Office of Healthcare Quality, which will assist in finding gaps in performance before you even get to the gaps in services. I worked as a public affairs consultant for 8 years with residential agencies for people with developmental disabilities and 2 years with psychiatric rehabilitation programs. And after working here as staff for over 30 years and as a lobbyist, let alone my brother is not able to navigate this system. And what is needed is empathy, compassion, and respect, which is lacking. So I come here asking for a favorable report on House Bill 1148.
Thank you. Thank you for sharing your story of your family. We really appreciate it, and thank you for the work you do, all of you. We're going to open it up for questions now for this favorable panel. Are there any questions for these 4 witnesses? Seeing none, thank you for being with us today. There is?
I'm sorry, yes. My question is for Ms. Monroe. Thank you very much for sharing your story. I know it's difficult. Can you speak to some of the challenges that you've had as a caregiver providing for your brother?
Sure, and thank you for the question. I'll just give you one quick example. This summer, my brother's been medicated by injection for over 20 years. And he has a certified nurse practitioner now as opposed to a psychiatrist. And my name is listed as a person to come to in order to talk about any care or whatever, which is rare. And he said that he didn't want to be on the injection anymore and told the certified nurse practitioner that he wanted to get a prescription and take the pills. So she wrote the prescription. He never filled it, and no one ever told me. So I spent the entire summer going back 40 years to a place where my brother had not been. And it was painful to watch. And it was pain. I could tell that he was in pain once he realized that that's not what he wanted for his life.
Any other questions? Delegate Woods.
Are there any other specific barriers to care for your brother?
Yeah, there's a lack of communication with the agencies. There's a lack of care coordination on the somatic side and on the psychiatric side. And one of the biggest things I'm facing as his caregiver, which is not something I planned, my mom just didn't want to deal with it because she was sick, is that when I asked about a higher level of care for him, I was told that he needed to be at risk for homelessness. So I would have to basically put my brother out of the house in order for him to get the care that he needed. This is what I was told. There's also a lack of follow-up with the social workers, which I haven't gotten. I've been looking for help. I've been calling on my own and calling assisted living facilities, and they don't have the proper staffing to care for my brother. So it's been super, super difficult. And my greatest fear with the level of stress that I'm under, to be honest, is something happening to me. And then there's just my brother. And I just don't know what would happen if I can't figure it out now. You're welcome.
Any other questions? Seeing none, thank you again for sharing your story. We really appreciate it. We have a couple of people for favorable with amendment. We have first, if you can all come as I call you, please. Dan Rabbit, Ann Seacock, Laura Howell, Deborah Ripken, Ellen Weaver, Pam Casemeyer. If you can all pull up a chair, please. As soon as you sit, will you start your testimony?
Sure. Thank you, Madam Chair. Members of the committee, my name is Dan Rabbit. I'm a policy director at Behavioral Health System Baltimore. We stand in strong support of HB 1148 and support all the provisions that, for all the reasons that other witnesses have said so far. We are favorable with amendment in that we think that local behavioral health authorities should be represented on the commission. Local behavioral health authorities are the county entity, county or jurisdictional entity that manages the public behavioral health system in counties. Most of the funding that the Behavioral Health Administration gets is passed through to the counties, to the local behavioral health authorities, and they play a huge role in contracting, accountability, planning, and really are invaluable partners in our public behavioral health system. So we think that they need to be on the commission for this commission to be as effective as we need it to be able to unravel some of these tricky questions. Our amendment asks for 2 representatives for local behavioral health authorities, one from a rural county and one from an urban county. And that we ask that respectfully for a favorable with amendment vote.
Thank you. Next, please.
Good afternoon, Madam Chair, members of the committee. I'm Ann Seacott, testifying today on behalf of several of our clients. The Maryland chapter of the National Council on Alcoholism and Drug Dependence, the Maryland Addiction Directors Council, the Maryland Association for the Treatment of Opioid Dependence, the Maryland DC Society of Addiction Medicine, and On Our Own of Maryland. And all of these organizations are in strong support of House Bill 1148. A lot of those organizations want to make sure that they're part of this commission. So I'm the person that Delegate Moon warned you of. And I know we can't have a 50-person commission, and so we're very happy to work in subcommittee to figure out the right balance to ensure people with the different and appropriate perspectives are there. And Delegate Lewis, thank you for your recommendation about someone from housing. We have included that as one of our recommendations, as well as public safety. We also just want to make sure that I think Delegate Lopez had mentioned that the number of work groups isn't necessarily limited. And so just some language to allow for other work groups to be developed or created as necessary. And then we also want to make sure that the Commission considers other issues related to parity, related to harm reduction, related to hospitals and how people with mental health and substance use disorders are dealt with there as well. So you've got the written testimony on all of this. We look forward to working with everybody in subcommittee, and we thank all of you who have been very supportive of this effort.
Next, please.
Thank you, Madam Chair, members of the committee. I'm Debbie Rivkin, Vice President, Government Affairs for Care First Blue Cross Blue Shield, in support with an amendment on this bill. I'm so excited to be able to support this bill. We've been talking about something like this forever. This committee has really spent numerous years talking about behavioral health, but really this is the first time that we're going to look at it in a holistic way, top to bottom, right to left, and really figure out where the needs and gaps are, and looking at best practices to how do we make the system work for everyone. And to me, this is just really exciting, and I'm thrilled to be able to support the bill. We have written testimony, which will give you a little bit more information on the 4 components in the bill and our support. The one amendment that we have is there's a small portion of the bill that deals with telehealth, and it extends out for 2 years. The telehealth law that we have today, The one piece that was missing is that the recommendations from the Healthcare Commission was to continue studying the impact of telehealth in terms of audio only and telehealth as it relates to in-office visits. And so all I've done is taken out the exact language that was in the recommendations from the Healthcare Commission's independent study and added that to this bill. Thank you very much.
Thank you, and thank you for all of you for your partnership. May I have Laura Howell, Ellen Weaver, and Pam Case-Meyer, please? And you can get started. Don't touch it. Thank you.
Yep, sorry.
It's
Good
okay.
afternoon, again, Madam Chair, Laura Howell, here today on behalf of the Maryland Developmental Disabilities Coalition in support of House Bill 1148. And we want to thank the bill sponsor for including a member of the DD Coalition on the commission established in the bill. People with developmental disabilities experience co-occurring behavioral health challenges at a higher rate than the general population, yet experience significantly more barriers to access and treatment. Families report that it's extremely difficult to find a mental health professional to treat their loved one with an intellectual or developmental disability. And when an adult has transitioned to community-based DDA services, it can be virtually impossible for community providers to help someone gain access to the treatment they need at times, which at times can include inpatient care. This results not only in people not getting the treatment they need, it also results in more pressure on hospitals and emergency departments as the only other option for support. People with developmental disabilities do sometimes wind up in forensic settings, referenced by the bill sponsor, and at times that can be avoided by access to treatment. So we have requested amendments that would add someone with a developmental disability to the commission and a family member. We understand that there are limits to those numbers, so we look forward to working with the subcommittee. And the last amendment we requested was to create a subcommittee to look specifically at the unique needs of people with developmental disabilities who have a co-occurring mental health issue. So we thank you for your consideration, and we urge favorable report. Thank you.
Thank you. Next, please.
Thank you, Madam Chair, members of the committee, for the opportunity to testify in favor of 1148 with amendments. I'm Ellen Weber with the Legal Action Center. We convene the Maryland Parity Coalition, whose mission is to expand access to substance use disorder and mental health care through the enforcement of the Mental Health Parity and Addiction Equity Act. We support the creation of the commission as well as the extension of audio-only telehealth and payment parity pending the MHCC study. Our proposed amendments, which are attached to our testimony, focus on the commission's purpose and task. In addition to the stated purpose of making recommendations on a list of particular items, we also believe that the Commission could serve a very important role by ensuring coordination of services of the many agencies that assist Marylanders with mental health and substance use disorder services. We also propose 3 additional priorities for the Commission's recommendations. First, the integration of substance use disorder and mental health care in general medical settings, which is absolutely essential to deliver effective care and to expand access to services. We also urge that this commission study the adoption of a full continuum of harm reduction services for individuals with substance use disorders. And finally, we urge the commission to examine the establishment of a consumer health access program to help Marylanders access treatment through all forms of insurance and to identify system-wide barriers to care. And finally, we propose several amendments to ensure that the Commission's work fully aligns with federal initiatives. First, federal and state parity laws require non-discrimination in both public and private insurance, access, and coverage. The Commission should ensure that all of its recommendations related to service coverage, reimbursement, and provider workforce meet this requirement. And then secondly, in expanding access to care for Marylanders who are incarcerated in jails and prisons, the Commission should include Medicaid reentry as one of its strategies. Through 1115 waiver authority, Medicaid, will pay for health services for a specific period of time before the individual's release. CMS has granted this authority to California. It will issue guidance soon. Thank you very much for your consideration, and we urge a favorable report with amendments.
Pam Case-Meyer.
Hi, I'm Pam Casemeyer, and much like you heard from Ann Seacott, I'm actually here on behalf of a large number of clients who are also very pleased to be here. I think there's multiple component parts of the bill, and I don't think I need to take up your time going over what you've already heard from so many of the proponents, because we heartily concur, but it's the State Medical Society, the Academy of Pediatrics, the Clinical Social Work Organization, a society, Mid-Atlantic Association of Community Health Centers, all very excited for the various component parts. The amendment piece of it, which has been referenced by other people, and I'm sure will be the subject of conversation at the subcommittee, is being sure that both the commission membership reflects all of the healthcare professionals that you need and other interested stakeholders and people that are there without making it too unwieldy, and also the charges of the subcommittees and what subcommittees and flexibility there. I think that'll all be issues and language that'll be looked at in the subcommittee, but did want to raise that as something that I think needs some further conversation. Other than that, it's a tremendous comprehensive approach to addressing these issues.
Thank you very much. Are there any questions for this panel and the panel prior? I can ask them to come back if you have any questions. Seeing none, thank you so much, all of you, for your testimony. And then we have Jake Whitaker. And I think you're the last person on this bill, Jake.
Great. Thank you, Madam Chair and members of the committee. My name is Jake Whitaker. I'm Director of Government Affairs at the Maryland Hospital Association, here to testify in support with amendments in favor of House Bill 1148. Maryland hospitals care for everyone who comes to their doors, but too often patients in crisis, particularly youth, visit hospital emergency departments due to a lack of behavioral health services in the community. This bill will help significantly improve and expand Maryland's behavioral health system of care, whether through the continued telehealth expansion, the funding of community behavioral health clinics, or the value-based purchasing pilot program. Maryland patients frequently access behavioral health services for the first time when in crisis during visits to hospital emergency departments. When patients have access to these services in primary care settings, patients can get the help they need on the onset of behavioral health conditions and stay out of crisis. Additionally, this bill builds on the success of the 2021 telehealth bill and extends the sunset provisions for audio-only modalities and the reimbursement parity for 2 years until June 30th, 2025. We also support the Senate bill that does the same thing, that extends telehealth for another 2 years. And we would hope that, and we worked with the stakeholders, including the insurance carriers, on moving forward with audio-only telehealth services. The reason we support with amendments is because we support the Maryland Healthcare Commission's amendments to conduct a final study to develop a conclusive plan on the role of telehealth in the healthcare system. We're pleased to say that when the Healthcare Commission's amendment, the Senate Finance Committee voted unanimously to continue audio-only services for another 2 years, and we hope the committee does the same for this bill. So for the aforementioned reasons, we request a favorable report with amendments on this bill. Thank you.
Thank you for your testimony today. Are there any questions for this witness? Seeing none, thank you very much, and thank you all for waiting. This actually concludes the bill hearing on House Bill 1148. We're now on to our last bill of the day, House Bill 626. Delegate Carlson is home. She's watching. She's not feeling well, but her chief of staff will testify on the bill. And we are also joined by Delegates Hartman, Vogel, and Wells. And the title of the bill is Animal Testing and Research, Human Relevant Research Funding, and Animal Testing and Research Licensure. It is jointly assigned to us in Ways and Means. I want to welcome Delegate Hartman. And if you have any questions when we come to that portion, will you let me know? You're welcome to sit here if you like, okay? Thank you. So we're going to have, if I may have the following panel. I have Kathleen Conley.
Yes.
Eric Galley, Keith Murphy, and Jim Corbett. Will you be so kind and come up, and you can pull a chair. Brigida, would you like to get started?
Yes. Hi. My name is Brigida Kristofic. I am the Chief of Staff for Delegate Carlson. Thank you for having me here today. Thank you for this opportunity to present HB 626, which is the Animal Testing and Research, Human Relevant Research Funding, and Animal Testing and Research Licensure. Ooh, a mouthful. This bill creates a fund to spur the development of human relevant research, driving the development of emerging research technologies that do not use animals. The fund is modeled after the Stem Cell Research Fund administered by TEDCO and includes a license fee on institutions that engage in animal testing. Maryland should be proud of its work on two fronts: to invest in its biotech industries and research institutions, and to create strong animal welfare protections. Specifically, I am referencing the Center for Alternatives to Animal Testing at JHU, at Johns Hopkins University, and the Emerging Biotech Center at University of Maryland. HB 626 will ensure that Maryland stays a leader as new non-animal testing methods move to the forefront. We're already seeing the impact that human-relevant technologies have on advancing human health and discovering cutting-edge solutions that animal testing could never have revealed. In fact, testing on animals is not even necessarily as accurate. 90% of drugs found safe on animals ultimately fail in human trials. Investing in these emerging technologies will take Maryland to the next level in our research, our biotech, and our life-saving interventions. Maryland has already established that we want to be a humane state. Legislature in 2021 passed a law ending the testing of new cosmetics on animals. The removal of 4,000 dogs last summer from a center that bred for research shone a spotlight on the inhumane treatment animals in research too often face. While those 4,000 dogs were able to start new lives in loving homes, more than 60,000 dogs are used in laboratory testing each year across the country. And we can move away from animal testing by investing in these innovative research that is humane. We are working with stakeholders on amendments as to the funding mechanism and to have institutions that test on covered animals, animals under the protection of the Federal Animal Welfare Act, to make contributions to the fund. That would not require new reporting or oversight, as those institutions already must receive USDA licenses and report the number of animals they test on. It would also strike the penalty provisions on the bill. This bill is a revenue-neutral way to move Maryland towards the future we want, one with solutions to the hardest medical questions, and one that is less reliant on outdated animal testing. There is broad stakeholder agreement with the amendments, and I respectfully request your favorable consideration. And with that, I will turn it over to the rest of my panel. Thank you.
Wonderful. Who will be next? And we've been joined, if I may, by the other members of the Ways and Means Committee, Delegate Vogel and Delegate Wells. Welcome. If there are any questions, please let me know, okay? You may get started.
Thank you, Madam Chair, Madam Vice Chair, also our sponsor, members of the committee. My name is Eric Alley, and I'm here today representing the Humane Society of the United States. I want to thank the sponsor, also the Vice Chair, for all the hard work she has done on the bill. I also want to thank Delegate Rosenberg. His stem cell research law was the model we used when drafting this legislation. Thank you for paving the way. You might say we stole his language. Depends on how you feel about it. He's been very generous about it, I have to say, so I think he's okay with it. We also want to thank our friends at the University of Maryland and Johns Hopkins University. They have worked diligently with us to make a deal on amendments that leaves them comfortable with the bill and leaves the basic principle intact, that we will do this important research and that those who currently use animals in testing will help finance it. I wanted to briefly review the amendments that the Humane Society, Hopkins, and the University of Maryland have agreed to. We have not had time to fully write them up yet. They're extensive, but the concepts are pretty clear. You will also find these concepts in the written testimony from Michael Huber of Hopkins. And those briefly, those items are: we're going to switch to the definition of covered animal in the Federal Animal Welfare Act, which is a big change. We were originally going to cover more animals. We're going to drop the licensing and fee structure, which will help significantly with the fiscal note. Wasn't the original reason, but it helps. And the licensing and fee structure will be replaced by a mandatory contribution for each entity based on how many covered animals are held that year. And the criminal penalties will be removed. So those are the fundamentals of the amendments, and we're very glad that they've worked with us, and we appreciate everyone's help very much. Thank you very much, and I'm happy to answer any questions about the bill. Thank you.
You're welcome, and thank you for working it with the advocates. Kathleen Conley.
Yes, thank you, Chair, Vice Chair, members of the committee. My name is Kathleen Conley. I'm Vice President of Animal Research Issues with the Humane Society of the United States and reside in Frederick, Maryland. I actually used to work for several years at a primate breeding and research facility, and I went in thinking I wanted safe and effective treatments for humans, and I left because I knew we could be doing better than we were for both humans and animals. So that's why I'm really excited about this bill today. The world is moving forward toward a future dominated by using human cells, 3D printing, computer modeling, and other technologies that do not rely on animals and only continue to get more sophisticated. You'll be hearing more about these from others on the panel. Animal experiments, on the other hand, will always have severe limitations. A mouse will always be a mouse, a dog always a dog. They will never be human. Animals have substances forced down their throats, into their lungs, in their eyes, on their skin, and they suffer for months or years before being killed. And we heard drug failure rates are extremely high, largely because we're taking misleading results from animals. So this has caused hospitalizations and even deaths. Government agencies are moving away from using animals and investing in these technologies, and really Maryland can get out in front as an investor in these. So as HB 626 establishes a human relevant research fund through an annual contribution, as we heard, by institutions using animals covered by the Animal Welfare Act. We appreciate the willingness of the institutions and engaging with us on possible amendments. And finally, really the public cares about this a lot. According to a poll earlier this month, Maryland voters, 79% of them favor investing in these technologies. So Maryland really could become a leader in 21st century science and increase human health and safety while also protecting animals. Therefore, we urge a favorable report on HB 626.
Who's
Thank
next?
you.
Thank you for your testimony.
I wasn't sure if I was called up
What
to
is
this
your-
panel
what is
yet.
your
Aisha
name?
Akhtar.
You can go ahead.
Okay, all right. Thank you, Madam Chairperson and members of the House Committee. Thank you for giving me this opportunity to present today in favor of HB 626. I speak to you on behalf of the organization that I have co-founded and am president and CEO, which is the Center for Contemporary Sciences, which is a nonprofit health organization based in Maryland. And I speak to you as a personal citizen and a neurologist and a public health specialist. One of the hardest things I have ever had to do as a neurologist is to watch my own aunt, a strong, incredibly vibrant human being, deteriorate from Parkinson's disease until she died. I watched helplessly as she slowly lost control of her arms, and a truly terrifying experience, as you can imagine, losing control of your own body's movements. Her arms pained continuously from the constant, uncontrollable tremors. Meanwhile, her legs refused to move increasingly until the end when she was unable to walk, to stand, and perform the most basic bodily movements that we take for granted. I tell you my aunt's story because there is not a single effective treatment for Parkinson's disease, nor is there an effective treatment for multiple sclerosis, dementias, spinal cord injury, most cases of stroke, and just about every neurological disease out there. And as a neurologist, having to tell and diagnose patients with devastating neurological diseases, it's incredibly difficult to tell them, I'm sorry, but there is no effective treatment for your actual disease, nothing that will change the course of your illness. In fact, there is no approved medical treatment for most human illnesses out there. And as you've heard, one of the large reasons that has come about in recent decades, and what I learned as a medical officer in the Food and Drug Administration, is that whatever role animal testing may have played in the past, it is now largely misleading results and causing the potential abandonment of cures and effective treatments. So I urge you to please vote in favor of this bill, help Maryland become a leader in exploring new ways of medical research, ways that are actually based on human biology, thus they are human relevant, they are kinder, they're more effective, and perhaps more patients like my aunt and future patients with neurological diseases won't have such devastating diseases to endure. Thank you.
Thank you. Mr. Murphy, can you please unmute yourself and give us your testimony?
Thank you, Madam Chair and Madam Vice Chair, for the opportunity to submit testimony on HB 626, critical legislation that would advance the use of non-animal testing methods in medical and product research and mark Maryland's commitment to developing safer and more successful drug therapies. I'm a biotech entrepreneur based in Southern California. I and those in my field appreciate your efforts, and I wanted to provide the perspective of an entrepreneur and innovator working on new non-animal testing methods. I am here to tell you that we are at the cusp of a major technological revolution. That technology exists today to dramatically improve our ability to develop drugs, improve the likelihood of success of drugs in clinical trials, and lower the costs of drug development and thus drugs themselves. For patients, this can mean new breakthrough therapies and lower priced drugs. But first, the technology needs to be taken up more broadly and more solutions need to be developed, which HB 626 grants will support. Several companies now are in the early stages of applying more modern technologies, such as 3D bioprinted tissues made from human cells from a patient, to avoid the species gap and over-reliance on rodent and animal models in pharmaceutical research. I am the Chief Executive Officer of Vizient Biosciences in San Diego, which has a superior model for liver fibrosis made from 3D human cells. Several major big pharma drug programs in this space have failed to reduce fibrosis in patients, and 2 have been successful. Animal models predicted all of them would work, but our 3D human model shows exactly which 2 reduce fibrosis and which ones fail to do so. These models and other technology to do better than animal models exist today and need support to be more broadly used. Our company is one of several, some of which commercially offer their models and their solutions to drug developers. Your efforts through this legislation would yield great benefit in making these models be used sooner and with greater impact. The result will not only be beneficial in the sense of less use of animal models, but will end the ethical tragedy that is using patients in experiments doomed to fail when the technology exists to avoid such practices.
Thank you for being with us. Mr. Corbett.
Thank you, Madam Chair and members of the Maryland House. My name is Jim Corbett. I'm the CEO of Emulate, a leading organ-on-chip technology developer, and I offer my support of House Bill 626. There's no doubt that animal models have contributed to major scientific advancements and to safe and effective drugs making it to market. However, these models have a difficult job of approximating the human body, and sometimes they get it wrong. Over the last 12 months alone, there are 6 high-profile examples involving well-known companies that saw drug-induced liver injury present a problem, either in terms of stopping clinical trials or, in one case, causing fatalities, after passing through animal testing requirements. 21st century science is proving there's a more safe and more humane path forward. In a recent study published in Communications Medicine, part of the Nature portfolio, researchers found that Emulate human liver chip to have this 87% sensitivity and 100% specificity when differentiating hepatic toxic from non-hepatic toxic small molecules. Importantly, all 22 of these hepatic toxic drugs in the study had previously been classified as safe due to a lack of toxicity in animal models. Collectively, these 22 compounds resulted in 208 patient fatalities and 10 liver transplants. Had the human liver chip been used during the preclinical screening of these compounds, it's likely that many of these fatalities could have been avoided. Moreover, researchers also found that improving our ability to detect hepatic toxicity with 87% sensitivity, it's estimated that the human liver chip can increase research and development productivity by $3 billion for the pharmaceutical industry on an annual basis. However, transitioning to human-relevant research testing methods requires funding programs in order to continue to spur scientific innovation. Funding programs for human-relevant research will lead to new education and career opportunities, as well as positive impact on the economy of Maryland. For these reasons and more, we urge the passing of House Bill 626. Thank you.
Thank you for your testimony. This is the first panel. I'm going to open it up for questions now for both committees, the Ways and Means and the Health and Government Operations Committee. Since there are guests, we're going to start with the Ways and Means Committee. Are there any questions? Seeing none, the Health and Government Operations Committee, we have Delegate Shalega.
Thank you,
Madam Chair, I almost called you Madam Speaker again.
I don't want her job. I'm happy where I am.
I feel better at least making that mistake here than on the floor. Can you tell me, is this going to expand embryonic stem cell research, or are there embryonic, parts involved in this bill?
No, this does not at all touch on embryonics research. This is using human stem cells from adult stem cells, often, or other types of human tissues that have been ethically derived, voluntarily derived, or discarded from surgical cases and so on. These are these are the tissues that make up these types of testing methods. That is correct.
Okay. I have Delegate Kipke.
Thank you, Madam Chairman. A quick follow-up to that question. Is there some information that you could provide in writing related to that so that we have something to back that up?
You can give it to us offline. Can you do that, please?
Yes, we can absolutely do that.
All right. Will you be so kind and send it to the delegate and the entire committee, okay?
Absolutely, yes.
And then to the virtual people, either Jim or Keith, I believe.
Yes.
Why is a government solution to this necessary? Why isn't industry moving in this direction without the help of government? Whoever is best equipped to answer the question. I assume both, at least one of the companies here is going to profit off of this. So I know why you might be interested, but can you tell me why it's necessary to have the government involved in this?
I'll jump in because my company will not profit off anything coming from your support of this bill. We don't sell any solutions. We're only developing our own drugs using our interior technologies, but I see a public policy benefit broadly for this because it's not going to move fast enough. Pharma scientists have been trained in the use of animal models. It takes them a long time to come to an understanding of how they should be used. There are very slow processes at work that will slowly turn over, but it's going to take a very long time. This is an opportunity to accelerate the breadth of the penetration of this throughout a broad set of uses, and Maryland researchers will be developing some of those technologies. They'll be first used in Maryland. So I think it's the speed with which we can benefit things akin to supporting any new technology with tax breaks or other things. This really allows it to, reduce drug prices. I think that's one of the biggest impacts. Create new drugs that won't exist otherwise faster, and reduce the cost of drugs sooner for Maryland residents.
Delegate Riley.
Thank you, Madam Chair. Yes, so I've heard a lot of testimony on the conducting medical testing, but we also have in the bill that it also addresses the product testing. Can you give me some examples of products?
Cosmetics, drugs, pesticides.
All right, thank you.
Any other questions from anyone? Seeing none, thank you very much for your testimony and for your work and your time.
Thank you.
Next, we're going to the
Thank you.
second panel. My pleasure. We have 4 virtual testimony. Will you be so kind and allow them all to come in, please? And for the witnesses that are waiting, thank you for being patient. For the committee, also, thank you for your time and your patience. Ms. Leary, will you be so kind and get us started while the rest of the panel comes on? How are you today?
I'm fine, thank you. It's all been very interesting.
That are waiting, thank you. Can you turn off the, yeah, then you can get started.
Just did. Thank you.
Thank you.
You bet. Well, good afternoon, and thank you, Madam Chair, Madam Vice Chair, members of this committee for providing this opportunity. We are testifying in support of HB 626. My name is Sue Leary, and I'm president of the Alternatives Research and Development Foundation. We've made grants totaling over $4 million to advance new approach research methods that do not use animals. These methods, as you've heard, are model systems based on human biology and comprise some of the really most exciting and innovative research in testing and biomedical research. So I have submitted written testimony. I ask that you take a look at that because it has more extensive comments and references. But today I did want to highlight that our nonprofit foundation has proudly supported a number of projects at highly respected research facilities in Maryland, which, as you know, has a unique concentration of scientific expertise. But I want to emphasize that we are well aware that more investment is needed. Our foundation can only do so much. We enthusiastically support this legislation's plan to establish a fund for human relevant non-animal testing and research. These methods show enormous promise to really break through and rapidly advance human health and reduce animal suffering, but a considerable investment is needed. The fact is that our experience has shown that incentives work and funding does motivate innovation. So as has been mentioned, some of these very exciting systems have been developed recent years, astounding progress developing these technologies, and this is recognized, and anyway, we support a favorable report on this bill. Thank you very much.
Thank you, Ms. Leary. Mr. Hickman?
Hello, thank you very much for the committee for allowing me to speak. I'm in support of this bill. And I just wanted to say is that I've been working in this area for about 30 years. And one of the founders, and I founded a company with Mike Schuler, who is considered the founder of the field, about 7 years ago. And we have been working with commercial entities to be able to expand the breadth of knowledge in this field, and also to try to educate people. And that's partially what I'm trying to do for this committee. And that the main thing is to try to get regulatory acceptance of these models in real animals. And it has to be understood that there's a big difference between looking at efficacy, does the drug work, versus looking at safety. And the critics of the bill are going to say that, well, you're going to always need animals, and they're correct for safety, okay? But not necessarily for efficacy, okay? And this is where we're at right now, where we're already developing models for efficacy. Our company has helped Sanofi to get a drug repurposed, okay, that had safety data in humans into a clinical trial with just efficacy data from one of our models. So the regulatory folks are actually in favor of this. And also, lastly, speaking for the chance of the rare disease community, is everybody says, well, either animals or these new microphysiological systems. But actually, for rare diseases, there's over 7,000 rare diseases, only 400 active research programs. So not only will you be helping diminish the number of animals, you'll also be helping a whole class of folks who don't have animal models to rely upon if you actually increase funding in this area in this bill. Thank you much for your time.
Thank you for your testimony. Mr. Armento.
Thank you, Madam Chair, and good afternoon to the honorable members of this committee. My name is Alex Armento, and I'm the president and CEO of MatTech Life Sciences, a Massachusetts-based biotechnology company and a global leader in the development and manufacture of human-relevant alternatives to animal testing for product safety and efficacy. We are tissue engineers, and we use human cells to create lab-grown, miniaturized human tissues which mimic the structures and functions of native human tissues. To date, we manufacture 15 different types of human organ tissues, both healthy and diseased, including skin, eye, oral, nasal, lung, intestinal, and vaginal tissue. These models have been cited in more than 1,000 scientific publications and more than 500 patent citations. In addition, 6 of our test methods, including skin irritation and eye irritation testing, have been fully validated by regulators as standalone alternatives to animal tests, such as the rabbit Drays test. We conservatively estimate that the use of our human-relevant tissue models by our customers in the pharmaceutical, personal care, and cosmetic industries have saved the lives of roughly 100,000 laboratory animals in 2022. Even more important than the ethical goal of sparing laboratory animals, the companies that are tasked with developing safe and effective consumer products and pharmaceutical therapies can obtain testing results that are much more relevant to actual human biological responses. My last point, MatTech is also a success story as it relates to government funding. Over the first 25 years of our existence, We were awarded several SBIR Phase 1 and Phase 2 grants to develop many of our existing tissue models and test methods to predict tissue-specific human toxicities. Although we no longer seek these types of government grants, MatTech has built a growing and sustainable business that will continue to lead in the field of human relevant testing. We now employ 75 people across scientific and administrative positions, and as we continue to grow our business, we'll always be grateful for the previous government funding that still allows us to have an impact in the field today. On behalf of our team at MatTech Life Sciences, I strongly support HB 626. Thank you for your time.
Thank you for your work, all of you, and your time. Ms. Fullerton.
Good afternoon. My name is Kim Fullerton. I'm Vice Chair of the American Bar Association Animal Law Committee, and I'm here today representing the Maryland State Bar Association Animal Law Section. I've been briefed on the amendments, and I do find them to be appropriate. And it's also important to note that with these amendments, the bill will be very narrowly tailored. So it will serve solely as a funding mechanism. It does not require new reporting or additional oversight. The penalty provision will be stricken, and the regulatory component is a completely separate bill. So the only issue that is presented to this committee in passing this bill is, as the delegate mentioned earlier, should Maryland promote state-funded medical research to develop human-relevant testing methods? And that answer is yes. It would benefit so many of the people and issues that we've heard about earlier today. And also, we have some of the best research institutions in the country. This bill would directly benefit them as well. This bill is how we accomplish those goals. The funding mechanism aims to be revenue neutral, and it will not depend on government funds to achieve our goals. The framework is modeled after another research fund, which is already administered by TEDCO. So we have high confidence that this bill is an effective strategy for driving critical research and more effective testing. To sum up, Maryland is already a hub for biotech and research. This bill is how we will preserve that interest while incentivizing research that benefits our state, our people, and our animals. Thank you.
Your testimony was excellent, very clear. Thank you. Are there any questions for these 4 virtual witnesses? First, Ways and Means.
Wish I did my first time in the front row, probably my last.
Well, you're welcome in HGO anytime. Okay, so we do have Delegate Martinez.
Thank you, Madam Chair. Could someone on the panel, or I guess just tell me how many organizations, foundations, or research institutions in Maryland currently conduct human relevant research?
Do any of the 4 panelists, if you know, will you unmute yourself? If you don't, it's okay. We can ask that question offline.
I can provide you more detailed information offline.
Thank you so much. Can you send it to Delegate Martinez and the entire committee as well, okay?
Absolutely.
Thank you very much. We have Delegate Hill.
Thank you, Madam Chair, and thank you all for being here and for this important work. Simple question. There's a lot of federal funding that's going into this same thing, National Cancer Institute, even the USDA. Why does Maryland need to provide additional grant and underwriting for this kind of research when the federal government and private institutions are already doing it?
Who will be the best person to answer? Okay, Mr. Hickman, you raise your hand. Go ahead.
Yes, the reason why was the one gentleman earlier said it best, is that to accelerate it. Okay, there is some investment in this field, but compared to the overall research endeavor out there in terms of pharmaceutical industries, animal models and things at NIH, this is only a very, very small fraction devoted to microphysiological systems, human on a chip-based systems. All we're looking for is to increase that and be getting any help, federal government, state governments, okay, as well as commercial funding for this area will help promote this faster, quicker, okay, and be able to alleviate suffering for patients who just don't have any other hope of using traditional methods.
Thank you. Any other questions from the committees? Seeing none, thank you very much. We do have two witnesses favorable. Can you come up, please? Miss Lisa Rada, Jennifer Bevan Dangle. Will you both come up, please? And as soon as you sit, if you can start your testimony, that would be great.
Good afternoon, Chair Pena-Melnick, members of HGO, and esteemed friends from Ways and Means. Thank you for the opportunity to testify today. My name is Lisa Radov. I'm the president and chair of Maryland Votes for Animals, here in support of HB 626. You've heard from people with way more scientific knowledge and expertise than I'll ever have. I'm here on behalf of all of our members across the state who want to see medical research move forward, saving animals at the same time, and also helping Maryland's economy, because Maryland does have a lot of world-famous research institutions as well as world-class hospitals. We feel that this would bring this to Maryland, and we say that it would be a win-win-win. Win for the economy, win for medical research, and win for the animals. And with that, I'd like to thank Delegate Cullison, whom I hope will feel better soon, and thank you all so much. And I would ask for a favorable report.
Thank you. Thank you for your work. Next, please.
Good afternoon, members of the committee. My name is Jennifer Bevan Dangle. I'm the State Director for the Humane Society of the United States. I'm just simply going to address a few questions that were raised throughout this hearing today. To answer Delegate Martinez's question, there's roughly 22 facilities in the state that test on covered animals. Now, it is important to keep in mind that a lot of animals, there's no reporting, there's no oversight, there's no federal license, so we don't know how many institutions in the state are testing on animals, but as far as these animals that are protected under the Animal Welfare Act, there is about 20. It's a pretty fair mix of institutions, higher education institutions, and then private corporations. So that's sort of the universe we're thinking of when we look at these fees. I do want to reiterate what Mr. Galley said about the fiscal note. We think that the amendments significantly streamline. We're eliminating the licensing, we're eliminating a lot of oversight, we're eliminating the reporting. So we are very cautiously optimistic that that fiscal note is in truth considerably lower than what was presented to you. And lastly, just to speak to some of the questions that have been raised around, why the state investing in this, why a government program. I do want to stress this state has made a commitment to biotech, and it is something that the state is proud of. It is something that we as Marylanders are proud of, that we are really a leading state for our research. Human relevant research is the part of that research universe that will move us into the next coming decades. You've heard from a lot of these emerging companies on the importance of these emerging technologies, but they are just that. They are emerging. And this will help incentivize, it will help accelerate, which is good not just for businesses in Maryland, as well as for people facing diseases who currently do not have a cure, and of course, for the animals. So with all of that said, we urge a favorable report.
Thank you. Are there any questions, Ways and Means Committee, for these two witnesses? The HGO Committee, Delegate Kerr.
Thank you, Madam Chair.
My pleasure.
The National Cancer Research Institute is in my district. Does this apply to federal property?
No, the state cannot put fees on federal institutions. So it's my understanding it would just be the 20 state-level institutions and private corporations.
Any other questions? Seeing none, thank you so much for your testimony today. We really appreciate it and for your work. Next, we have a panel of favorable with amendment. The first one I'm going to call, as I call you, will you please come up and pull some chairs? I would like to call Gregory Ball, Brendan Cannon, Eric Hutchinson, Joseph Menkowski, and will you be so kind, as soon as you sit, if you can please, the first person that sits, start with your testimony. Thank you very much. You can get started.
Thank you, Madam Chairman, and thank you, members of the committee, for giving me an opportunity to testify. My name is Greg Ball. I'm the Vice President for Research at the University of Maryland, Baltimore, and the University of Maryland, College Park. I'm coming to give a favorable report for this bill, important to note, with amendments. This is an extremely important bill to the biomedical research entities here in the state of Maryland, which has been noted provide us with great strength in the economy and in our educational opportunities and in our research. A couple of observations are important to note. First, we are required, all of us using animals, to get approval through our Institutional Animal Care and Use Committee. Built in to those protocols that we have to write are a discussion of how we are going to mitigate the use of animals and figure out ways to use the appropriate sample sizes to minimize it. So those kinds of things are built into the culture right now. Similarly, all animal protocols have to have a section in which they discuss how they have considered alternatives to animal research to see if there are ways to do this without using animals. So a lot of the concerns and issues raised are already addressed and in place in our institutions. And finally, I just want to note, modern medical research cannot be done without a combination of techniques. And there are many exciting techniques that occur in cell lines and also in computer simulations. But make no mistake, work in intact animals is essential for many extremely important questions. We cannot mimic the brain in AI yet. We're not close. And I would just like to note, I was speaking to one of the neurosurgeons at the University of Maryland Hospital about his research in using focused ultrasound on glioblastomas. One of the many neurological diseases which has evaded treatment are tumors, and he's using ultrasound tested in animals that is now being effective in humans. And if he didn't have the ability to test in situ in the animals, he couldn't do it. Thank you.
Thank you, and thank you for your work. Next, please.
Thank you, Madam Chair. Thank you, Madam Vice Chair. My name is Eric Hutchinson. I'm a veterinarian. I'm the attending veterinarian for Johns Hopkins University, as well as the Assistant Vice Chair for Animal Research, as well as the Director of Research Animal Resources, and an Assistant Professor of Molecular and Comparative Pathobiology. I want to thank you for the opportunity to testify in favor of HB 626 with amendments. Johns Hopkins has already submitted written testimony, so in addition to the points made there, I wanted to take my time today to talk about the care that we give to the animals in research. My work focuses on the treatment and environmental enrichment of animals used for research testing across Johns Hopkins. My care for them includes both basic health care and reducing pain, but it's also a lot more than that. It's about creating quality environments for the animals, maintaining their normal behavior, and caring for their mental well-being. As a veterinarian and as a recognized expert in animal behavior management, I take very seriously the need to ensure the animals under my care and their well-being is taken care of. Simply put, my job is to take care of them and make sure that they're happy and healthy. As a research scientist, I take very seriously the idea that research involving animals remains a critical tool in the toolbox of scientific discovery. Medical advances, drug therapies, countless treatments all still require the use of animals in order to discover them. These aims are not in conflict. We at Johns Hopkins are one of the biggest users of alternatives in the state. In fact, most animal experiments start with an alternative, one type or another. You don't take a new drug therapy and stick it into an animal. You're testing it in a cell culture, you're testing it in some sort of model first. And so alternatives are almost a necessary part of animal testing anyway. So we are in support of the aim of this bill to continue to develop in the state of Maryland alternative technologies. And so I respectfully urge the committee to issue a favorable report with amendments.
Thank you, and thank you for your work. Next, please.
Madam Chair, members of the committee, my name is Brendan Canning. I'm a professor of medicine at Johns Hopkins, where I also serve as the chair of the Animal Care and Use Committee. All research proposals that require use of vertebrate animals at Johns Hopkins are reviewed by the Animal Care and Use Committee, and no work can proceed until all of the planned procedures have been reviewed and approved by my committee. I want to thank you for the opportunity to testify in support of HB 626 with amendments. Fundamental to our role in providing oversight of animal care and use at Johns Hopkins is our adherence to the 3 R's of research involving animals. And these are replacement. Whenever possible, use alternative to animals. Reduction. Employ methods that reduce the number of animals used without sacrificing the quality of the research. And then finally, refinement. Use approaches that minimize or eliminate pain and distress in animals. Investigators at Johns Hopkins proposing research involving animals must formally demonstrate that they've considered reduction, replacement, and refinement in their study designs. If they haven't, their work won't be approved and their work will not proceed at my institution. You've heard from my colleagues as they discuss the oversight and the care provided to these animals. I just want to use my remaining time to emphasize the still essential role of animals in biomedical research. Johns Hopkins shares this legislation's goal of developing alternatives to animal testing. Progress in this area of research, as we've heard, has been impressive and inspirational, but at present, biomedical research could not continue to provide the breakthroughs or understanding of human diseases, much-needed treatments, without the use of animals. I urge the committee to support continued development of alternatives to animal testing, but without hindering the pursuit of scientific breakthroughs that will benefit society. I urge a favorable report with amendments.
Thank you. Is there a Joseph McConkey?
Madam Chair, I'll let you know Dr. Menkowski was unable to join us today.
Okay, great. Thank you. Thank you all. We're going to open it up for questions now from the Ways and Means Committee. No questions. HGO, we have Delegate Bagnall.
Madam Chair, this is just a clarifying question for Mr. Ball, because I didn't see in your written testimony the amendments you were requesting. Are they the same as
Yes.
requested by Johns Hopkins?
Johns Hopkins and University of Maryland are in complete sync on this matter. We discussed it extensively, and we completely agree.
Thank you very much. Thank you, Madam Chair.
My pleasure. Any other questions for these three witnesses? Seeing none, thank you for your time and your patience. We really appreciate it, and for the work you do in Maryland. Next, we have our final witness of the day, Ms. Laura Buckley. Good afternoon, ma'am. How are you?
Doing well, Madam Chair. How are you?
I'm doing well. Thank you for asking. Thank you for your patience.
Of course. Thank you, Madam Chair, and thank you, members of the committee, for the opportunity to speak with you today. My name is Laura Bogley. I'm Executive Director of Maryland Right to Life, and we are asking for an unfavorable report on this bill. We absolutely support any ethical cures for human suffering and disease, but the way this bill is written so broadly, it may allow unethical research that could commit public funding for inhumane biomedical or commercial research that destroys human beings in their embryonic or fetal stage. Human relevant research is an evolving field that is largely undefined. There's nothing in Maryland law that prohibits fetal or embryonic tissue or stem cell testing. In fact, the Maryland Stem Cell Research Fund itself does not prevent any fetal or embryonic cell or tissue testing. So without your specific legislative guardrails, an enactment or prohibition of specific legislative guardrails, the definition of human relevant research could continue to expand to also include the destruction of embryonic or fetal human life. Humane treatment is characterized by compassionate care for both humans and animals, and the state should resist policies that seek to avoid animal cruelty by being cruel to vulnerable human beings who deserve your protection. That is, in fact, what was enacted in 2021 with the cosmetic tissue or cosmetic testing that allowed testing on human beings but not non-human animals. Human embryonic and fetal tissue research is fraught with ethical and scientific pitfalls and has failed to cure any disease. Conversely, there are proven ethical alternatives to destructive research methods. We ask you to be careful to avoid creating financial incentives for researchers to destroy preborn human life and to instead incentivize ethical alternatives. If you do not require a higher standard of ethical testing methods, you will not receive it. Thank you.
Are there any questions? I don't see any. Just wanted to let you know that the bill has been and will be heavily amended. Everything is gone. I mean, everything. The only thing left in the bill is the funding mechanism. Of course, we don't have the amendments, all of it yet in front of us, but you'll get to see that there isn't much left in there except the funding mechanism.
Thank you, Madam Chair.
My pleasure. You take care.
You too.
All right. Thank you very much. This actually ends the bill hearing on House Bill 626. I want to thank the witnesses for being patient. I want to thank the Ways and Means Committee for being with us today. And also the committee, thank you for your patience. Really appreciate it. As you heard earlier, Delegate Bagnall will be the new Public Health Chair. If you would please welcome her. As well, look forward to working with her as well. Please keep Delegate Collison in your prayers, and I'll see you later tonight. Thank you so much for being patient, okay? And I want to thank staff for their hard work and Alejandra for volunteering a second week. Thank you. She gets room and board. Thank you. I'm so grateful that you did that.